Good morning, everyone. Thank you so much for being here. And for those that are on the live stream, hello. We hope that we have a lot of folks watching and participating. And we are really excited to be here for the Pfdd meeting for LGS and the DEEs. This is a really big deal for us to share our voices with the FDA and be heard and speak on behalf of our loved ones. So my name is Christina Santinocencio. I'm the executive director and founder of the LGS Foundation. I have a 31-year-old brother with LGS, and you'll hear a little bit more about him in my testimony coming up. But I just wanted to do a quick introduction and also show a video that's about 4 minutes long. But before I do that, I just wanted everyone to get comfortable in the room, and if you could just reach over to your neighbor, to your either left or right, and just introduce yourself and just for literally 30 seconds and say hello and why you're here. A lot of you may know each other already, but I think this is a good opportunity for those that don't know each other to just get to know. There are a lot of families in the room that have traveled from all over the United States to be here. So we are represented by, I think, what is it, Kathy, 14 states? So this is a really good opportunity for everyone to get to know each other. All right, well, with that, thank you for getting out of your comfort zone and introducing one another. And with that, I'm going to show the video that I just mentioned. And there are tissues on the table. You may need them, but here we go.
Lennox-Gastaut syndrome, or LGS, is a rare and catastrophic form of epilepsy that begins in childhood. It is one of the developmental and epileptic encephalopathies, which are severe disorders of the brain. LGS starts at a young age and consists of an abnormal EEG, multiple seizure types, and eventual cognitive and behavioral abnormalities. It can sometimes lead to early death.
Kanan was 3.5 and typical, and he had met every milestone. He gave great fishy kisses, and we were big, avid season ticket holders for Oklahoma State, and he was a boy's boy.
And my daughter Spencer is 14 years old. She was diagnosed with LGS when she was 7. So until then, we didn't know anything. It was just a real mystery.
For about a year after we got diagnosed with epilepsy, Kanan's seizures began to progress and get much worse. He started having multiple seizure types and was getting really hurt because he was having drop seizures at this point.
With LGS, there is always an evolution. After the first seizure presents itself, other types of seizures will emerge. Those with LGS have frequent seizures of multiple types. 30 to 50% of individuals with LGS have infantile spasms prior to developing LGS.
Amari was diagnosed first with infantile spasms when she was 2 months. It was devastating. It was so devastating.
Lily was having between 800 and 900 seizures a day at that time. Her brain was pretty much on fire.
Most living with LGS are typically treatment resistant, have moderate to severe developmental delays along with regression, and may experience behavioral disturbances, regular injuries, multiple hospitalizations, and more. Many rely on wheelchairs and have frequent rescue medication use.
That first couple of years was rough, and he got all of the bad side effects from those drugs. He got a rash, he got, sleeping all day. It's rough not only with that, with the medical side, but on the family as well.
LGS impacts every aspect of daily life for the individual living with LGS and for their families. They face a high risk of sudden unexpected death in epilepsy and other life-threatening injuries and illnesses.
What scares me is me dying before she dies, and I don't want to, but I'm waiting for her to die before me so I can finally die in peace, knowing that she was taken care of.
I just feel for any parent that has to see their child lay in a hospital bed and go through what all of our children go through. It's very scary because you never know when their life is going to end. It can be any time.
However, there is hope for those living with LGS and their families. The LGS Foundation is leading the charge to improve the lives of individuals with LGS through research, family support, and education.
There are no words really to explain what the LGS Foundation is doing and what it means to these families.
These people make me feel like that I can loosen up and I can ask questions and I can say things that I need to say.
But there's still a lot of work to be done. Better therapies are needed that can help improve quality of life, reduce seizures, and give families peace of mind for their loved ones.
It's hard to watch your child and not know how to help because it's really not treatable at this point. And so you just do all that you can.
We at the LGS Foundation will never give up advancing support, education, and research. We are determined to fight for those living with LGS.
The work we're doing is really important, and the change we want to see for our loved ones, we are not stoppable.
It's a pretty powerful video. Today also is International LGS Awareness Day, in case you didn't know. And our colors behind me are purple and green. So at some point we'll try to take a picture after this meeting concludes and try to get all of you in it to show our solidarity. Thank you again for being here. And at this point, I'd like to introduce Dr. Tracy Dixon-Salazar, who is our Director of Research and Strategy at the LGS Foundation, and she's going to lead us off into the next segment. Thank you.
Great. Thank you guys so much for being here. This meeting really means a lot to us, and we feel very supported having you all here. So you might be wondering why we're having a meeting on DEEs and LGS, developmental and epileptic encephalopathies, and Lennox-Gastaut syndrome. So thank goodness for acronyms and DEEs and LGS. And the reason is because the two are inextricably linked. You can't think about LGS without thinking about DEEs. Every kid with LGS, every adult with LGS has at least 2 DEEs. My child has 3. She had intractable epilepsy with developmental delay, diagnosed at age 3, then LGS diagnosed at age 5, and then a genetic disease, which her LGS is second to, diagnosed at age 18. And if she had had infantile spasms, that would have been 4. So they're linked in that way. And the reverse is true as well. You can't think about the DEEs without thinking about LGS, because all of the DEEs, if you have any kid who has seizures that start in early childhood, that don't get controlled, that turn into more than one type, they are at risk of developing or metastasizing, if you will, into LGS, where the seizures take over brain development. You get very abnormal patterns on EEG, for their brain waves, and it's just not a good sign. The chances of you responding to medicine at that point are very low. So the two are linked. So at the LGS Foundation, we couldn't just host a meeting on one or the other. And so here we are, we're hosting this meeting, and there's a lot of different stakeholders in the room. So all of us, for better or for worse, are in this together to try to help the families that you're going to meet today. Thank you to the FDA for letting us host this meeting, giving us the opportunity. We know that when you approve therapies for LGS and for other DEEs, that you look at safety and you look at how well it works and whether it's tolerable. But you also look at the burden of the disease, and you look at what the treatment burden is to the patients. And for the first time, we're coming forward and telling you in our own words as patients and families living with these things what that's like. And we'll write it up in a very nice report at the end, which hopefully will mean better treatments and more comprehensive treatments where our voices are heard and are part of the decision-making process. So thank you for having us. Also in the room are our friends from the Rare and Catastrophic Seizure Collaborative and the Rare Epilepsy Network. So all of the other DEEs, if you will, have come in support of us. And thank you guys. I mean, I'm looking around, I see SCN2A families, I see SCN8A, I see CDKL5 deficiency families, DUP15Q, tuberous sclerosis. All of these families that have those DEEs have a risk of developing LGS. And if you guys fix it early, you know, if you guys can target the cause, that'll mean less LGS. So we support you and we're here for you, and we thank you for being here to support us in this meeting and talk with us. Yes, thank you. And I know many are watching from home. I mean, there's so many groups that we just adore. I have to thank the families. There are families here. You're going to hear 9 testimonies today, and then you're going to hear from the families that are in the room. And if you're watching live, you can comment online. You should have gotten an email address to send your questions and comments to, and we'll be checking in. But the families have really come out. There's a survey that the families filled out, and the data is in the program on what it's like living with this condition, how severe the condition is. And we had 413 families respond to this survey, so we could collect this data to start to look at how many seizures are they having, how often are they going to the hospital, how many meds are they on. And then they're here, and I'm looking around at all of the families, and I am one of them. We're asking nothing short of having you take off this armor that you've put on, years and years of armor, and rip the bandages off the wounds and hold them up to the light so everyone can see. And I know it's hard because I'm doing it as well, and I know that it's not pretty, but thank you for your courage. 20 years ago, when Savannah, my child, got sick, nobody talked about the severe epilepsies. Nobody talked about epilepsy, really. And so this is pretty monumental that we're out and we're talking about it. And you will be heard today, and change will come. And a lot of us know that that change might not help our loved one. It might be for the next generation, but we just want it to be better. And then I also just want to say for the families that are here and that are listening, when this meeting's over and you have to put that armor back on and go home, and go back into the world that we live in, that the foundation is here for you, that all of the DEE groups in the Rare Epilepsy Network and the collaborative are here to support you if you need it. So we don't have a lot in the DEE community, but we have a community that will support you if you need it. We will try to help you. So, and then finally we have, not finally, but we have our sponsors who have sponsored this meeting, and I promise you that there are so many people that would not have been able to come to this meeting, nor would we have been able to host it if it hadn't been for you guys coming forward, providing scholarships and helping us to do this. So thank you so much. I know there are other people in the room, but if you look around, this is us, that this is the group, that we're all in this together to really try to make a difference for these families. I'm looking, I see the Epilepsy Foundation, I see NIH representatives. So things are going to change, and this is the beginning of a dialogue, and I'm very excited about it. And with that, I think we're going to move into a couple of housekeeping things. So we have a packed agenda, packed. So if we don't have a break scheduled, if you need one, please go. And I believe there's going to be coffee and refreshments out here if you need to grab them. Please turn off your cell phones. If you are watching live, you can email. So I will send out the link again so you guys have that. We'll post it up on Twitter and on Facebook so you have that. And just to remind everyone in the room that we are filming this, and if you didn't want to be on camera, you needed to be in the back rows there, which I see are nice and full. No one's up here in the front. So Right, because a few of us, right. So with that, then, I would like to just say thank you one more time. I think everyone in this room, you're going to get thanked at least 20 more times before the end of this. This really is a privilege for us to be able to share our stories with you, and you're going to want to have some tissues nearby because it's been a rough couple of months prepping for this. So with that, I want to turn this over to the FDA and hear their remarks. So I'd like to introduce Dr. Michelle Campbell. She works at Seizure, which is the Center for Drug Evaluation and Research. And she spends all her time thinking about, okay, maybe not all your time, but a big chunk of your time thinking about what matters to patients and how you measure it. And I don't know about you guys, but I'm really glad that there's somebody that thinks about that kind of stuff, because boy, could we really use that type of stuff in the DEE and in the LGS world. And that we've started this conversation so we can begin to think about better ways to develop therapies for our loved ones, because while we're doing okay, there's a lot of improvement, as you guys are going to see. So Dr. Campbell, I'd like to invite you up to give a few comments about these meetings, and thank you for being here.
Thank you, Tracy. And good morning. As Tracy said, my name is Michelle Campbell, and I lead stakeholder engagement and clinical outcomes in the Division of Neurology Products. First, I'm happy to see so many patient, caregivers, and advocates in the audience today, and we know a lot more is on the web as well. Thank you all for being here and being a part of this meeting and sharing your experience with us. I would also like to thank the LGS Foundation and all of their staff that were involved in planning this meeting. I know we have representation from our industry, academia, and other medical product development stakeholders in the room and as well online. While FDA plays a critical role in medical product development, we are just one of the parts of the process, and I'm glad to see a high level of interest for those who also play an important role. Additionally, we have colleagues here from various offices and centers from FDA who are attending both in person and on the web. We share the patient's community's commitment to facilitate the development of safe and effective medical products for developmental and epileptic encephalopathies, including LGS. Know when we say medical product development, we mean that in the broadest sense of identifying, developing, and evaluating potential therapies and devices that can help patients manage their conditions. We are here today to listen and to learn from you and your experiences with DEEs and LGS. FDA protects and promotes the public health by evaluating the safety, effectiveness, and quality of new products, but we do not develop medical products or conduct clinical trials. It is, however, FDA's responsibility to ensure that the benefits of the product outweighs the risks. Therefore, having this kind of dialogue is extremely valuable for us because hearing what patients care about can help us lead the way and figure out the best way to facilitate medical product development and understand how patients view the benefits and risks of therapies and devices for DEEs. We look forward to incorporating what you learned today into the agency's thinking and understanding of how patient views benefits and risks of therapies and devices for DEEs. We thank you for your participation. We are grateful for each of you for being here and sharing your personal stories, experiences, and perspectives. So thank you, and I'll turn it back over to Tracy.
Thank you so much. I appreciate that. And this is a great program. Like, I don't think I get to say very often that the FDA did something really cool, but that's pretty cool that we actually get to talk and we're listened to. So thank you. I want to introduce now Dr. Knupp, and when I was saying, you know, how should I introduce you, or what title should I give, I was told that I should mention why we invited her. And so the first thing that came to my mind, which is never what I should say, which is what I'm going to say anyway, was that when she gives talks at professional meetings, which we both go to a lot of them, she activates the advocate in me. And there are times where I'm nodding my head and I just want to stand up and say, can I get an amen for that thing that she just said? And I don't ever say, can I get an amen for anything? But when she talks, she gets it. She talks about things that are important to patients, And it all comes from a compassion in her. And she takes the compassion. I mean, she sees these patients every week. She treats a lot of our families. And she turns it into an effort to try to make lives better. She studies comparative effectiveness in infantile spasms, of which so many kids evolve into LGS, too many. She looks at prevention, this concept of preventing the evolution to LGS and other severe DEEs. And she gets it. She gets the time is brain. And if you let seizures go unchecked in a very young child, that it can irreparably cause lifetimes worth of damage and even death. And so she cares and she tries to help. That's why she's here. And she's also a very, very good doctor and knows a lot about the DE. So she's going to be talking about that. And she's professor at Children's Hospital in Colorado. So Dr. Knepp, come tell us about the DEEs.
That was quite the introduction. I don't know if I can live up to that or not. Thank you for inviting me to speak and for organizing this. I am actually deeply humbled and honored to be in this position. I feel like there's some feedback. Are you guys hearing feedback? No? Okay. It's just me. I'm getting old and I have ringing in my ears. So I'm going to speak to you about Lennox-Gastaut syndrome and developmental and epileptic encephalopathies. And my job is to give everybody an overview of what this syndrome looks like, to get us all off on the sort of beginning of this. But I think that families are really going to be able to tell the best story for this because they truly are the experts. They live this every day, every second of every day. So, but just to start off and clarify some terms, we've talked already about developmental and epileptic encephalopathies. There's some official definitions up here that are being used for this. These are two terms that we use that many children actually have both. So an epileptic encephalopathy is where your brain is not functioning the way that it should because of epileptiform activity. And this usually starts with seizures, and then in turn, we start to see epileptiform activity on an EEG, and then that has an impact on development. And so that's an epileptic encephalopathy. We also talk about developmental encephalopathies. We know that many children who have seizures have encephalopathy. Their brain isn't working the way that it should, but they don't have this epileptiform activity. And it's really important for us as providers and for you as families to understand the difference, because with an epileptic encephalopathy, we would improve development and cognitive function if we can improve that epileptiform activity. So it gives us a target and some hope. Whereas developmental encephalopathies, we may not be able to make that change just by treating the epileptiform activity. So that's great in theory. It turns out it's really difficult to treat that epileptiform activity. We are learning more about this, but we really have a long way to go. So I probably have already covered most of this slide, but the concept of epileptic encephalopathy is that in many children, we see these frequent epileptiform activity, these discharges. A single discharge in itself only lasts a fraction of a second, but over time, if it builds up, it actually can go on for quite a long period and impair the function of the brain, so the brain can't do what it's supposed to do. There's some really clarifying patterns that we see and that we recognize. Slow spike and wave, which is something that we see in Lennox-Gastaut syndrome. Hypsarrhythmia, something that we see with infantile spasms. And then for other children, we may see something that's a little bit nondescript, but that we call multifocal discharges. And so we know in hypsarrhythmia or in infantile spasms, that we can't just treat the clinical seizures. We also have to treat the hypsarrhythmia and make it go away to have the best outcomes. And we presume that the same is true with Lennox-Gastaut, that we need to make slow spike and wave go away to have improvement in encephalopathy in these children. There are some children who have seizures who don't really have epileptiform activity, and those children don't have an epileptic encephalopathy. They may still have encephalopathy, but it may not be related to this. What is really important to keep in mind, and you'll hear this from families today, is that the preceding development may actually be normal. It could be delayed.
We may see plateaus in development suggesting that there's an epileptic encephalopathy. We may see regression, and that may happen once, or that may happen several times, and it may be stepwise where we see progressive regression over time. These are all things that as providers we have to listen for to suggest that somebody may have an epileptic encephalopathy. And you guys know your children best. When we're talking with families, you have to tell us this. Families always tell us this. We may not always listen for it, but we really need to make sure that we're paying attention to this. And there can be lots of triggers for this: seizures, infection, brain edema, and we need to try and figure this out. We know that there are several age-related epileptic encephalopathies, and several of the classic ones are listed here. See if I can figure out how to use the pointer. Lennox-Gastaut syndrome is on here, but we see that this is age-related. These are very young ages as we get older. And so if we follow this down, Lennox-Gastaut we usually start to see around 3 years of age. You can see there are a lot of encephalopathies that happen before that, and some of these may actually evolve into Lennox-Gastaut. Ohtahara syndrome, West syndrome. Some children with Dravet syndrome actually meet criteria for Lennox-Gastaut syndrome, so there's a lot of overlap between these. And as Tracy mentioned, many children may have several diagnoses, all of which are correct, and may also have Lennox-Gastaut. So what is Lennox-Gastaut? As neurologists, we talk a lot about history, so I just wanted to kind of briefly go over this. Lennox-Gastaut has been around for a while, but not quite a century. The EEG findings were first described in 1939. In 1950, several decades later, there was a correlation of seizure types with the EEG findings. Dr. Dravet, who's also known for Dravet syndrome, probably one of the best clinicians I've ever met, described Lennox-Gastaut syndrome in 1965. She's a great observer of patients, and she really listens to parents. Dr. Gastaut actually published 100 cases a year later and called it Lennox syndrome. And then Niedermeyer, who's basically written our Bible of EEG, called it Lennox-Gastaut syndrome in 1969. So that's where the name came from. That's sort of the history behind this. So how do we define Lennox-Gastaut syndrome? I think we've heard some of this definition already. We do have trouble defining Lennox-Gastaut syndrome. We sort of feel like we know it when we see it, but it's a pretty broad definition, and it gets a little bit tricky for us. According to the ILAE definition, the International League Against Epilepsy, we have to see tonic seizures during sleep, slow spike and wave, paroxysmal fast activity, and an abnormal background EEG. And we may see many other seizure types. I'm not sure I've ever seen Lennox-Gastaut that didn't have other seizure types. So I think that while it's in the may category, I think it's always present. One of the tricky things is we may not see these things all at the same time, and they may actually come and go throughout the lifespan. So this is something that we typically evolve into and see as children get older, but it may actually go away. So if somebody hasn't performed an EEG to look for slow spike and wave, done an overnight EEG looking for tonic seizures, they may actually miss this diagnosis. And so it's something as clinicians we have to be very aware of, and something probably as parents, unfortunately, you need to advocate for, because we are not as good as we should be as clinicians. Dr. Bourgeois actually gave sort of a nice description of how he thinks about Lennox-Gastaut, which I've included up here. He thinks of it as 3 different categories that come together to create Lennox-Gastaut, with multiple seizure types, including those tonic seizures, an abnormal EEG, and cognitive impairment. You can see that doesn't completely match the ILAE definition, but I think it's a nice way to conceptualize this. And just in case nobody has seen slow spike and wave, I've included a picture here. The lines separating here are 1-second bins, and we can see the sharp activity is pretty frequent and is occurring a couple times every second, and this is characteristic of slow spike and wave. One of the things that is really important about Lennox-Gastaut is it is a syndrome. It is not a final diagnosis, and everybody who has Lennox-Gastaut really should have at least 2 diagnoses, because there are lots of etiologies that are associated with Lennox-Gastaut. Unfortunately, we do see about 10 to 25% of people who don't have an identified cause, but everybody should always be working for an identified cause. So whenever I'm working with one of our trainees and they tell me somebody has Lennox-Gastaut syndrome, my next question is why? Why does this child have Lennox-Gastaut syndrome? Because that may guide some more specific treatment for that particular patient. There are a million things that can cause Lennox-Gastaut syndrome, from brain malformations, stroke, hypoxic ischemic injury, infection, tuberous sclerosis. This is just a beginning of some of the genetic etiologies. I could probably fill up another 3 slides with genetic etiologies that have been associated with Lennox-Gastaut syndrome. So it's really important that we try to figure this out because it may actually help guide management. Unfortunately, we don't always know who will evolve into Lennox-Gastaut. So for instance, children with tuberous sclerosis complex often get their diagnosis of TSC very quickly early on in their presentation. But it's very difficult for us to predict who may go on to evolve into Lennox-Gastaut. So it's something that we also, for some of these diagnoses that happen early, we have to keep in the back of our mind, is this evolving into an epileptic encephalopathy? And fortunately, although a little confusing for us, we are entering a new era in pediatric epilepsy where we are seeing a huge amount of genetic disorders. I was recently at our national meeting and somebody said it just feels like alphabet soup, and it kind of does. Lots of people are ending up with genetic diagnoses that are sort of this combination of letters and numbers, and we have to decipher that. And it's very exciting because probably many of the children who don't have imaging abnormalities on their MRI may ultimately have a genetic diagnosis, and it's really nice to be able to make that diagnosis and sort of end this odyssey of trying to figure out what is causing this. But it does present a challenge to us about how to treat this, and do we have some more specific treatments? And I think we're entering an exciting era as we figure some of this out. So I probably could have done this whole talk with just this slide here. I think this is a really important overview of Lennox-Gastaut, and you will see this again at the end because this is the picture I want you to keep in your mind. Whenever we look at Lennox-Gastaut, as I've already mentioned, we see lots of etiologies. But Lennox-Gastaut is something that evolves over time. So it often starts with that first seizure. Whenever we see somebody with a first seizure, we do not have crystal balls, and it is very difficult for us to know what will happen in the future. And as families, that's really a scary time to be in as well. Nobody wants to sit in my office. Nobody wants to see a pediatric epileptologist from that very first seizure. Once you have a second seizure, you've evolved into epilepsy. Many times there's some evaluation that's occurring to try and figure out why you have epilepsy, which usually involves an MRI and some lab testing and lots of detailed history and exam. Once you have failed 2 medications, then you move into treatment-resistant epilepsy. And you may have another epileptic encephalopathy diagnosis at this time, whether it is West syndrome with infantile spasms or early infantile epileptic encephalopathy, some of those epileptic encephalopathies that I showed you on the other slide. And then over time, we may see evolution into Lennox-Gastaut. And I think this is definitely something that our family experts are going to talk about today because it is quite an odyssey to get to this diagnosis of Lennox-Gastaut. And part of it is this evolution. Part of it is not making the diagnosis soon enough. And that's something that as providers we need to continue to work on. Once somebody has Lennox-Gastaut, at that point we have usually seen more than one seizure type. We see slow spike and wave on EEG. We also see something called paroxysmal fast activity on EEG, so those are things that the epileptologist should be looking for. Unfortunately, we're starting to see cognitive impairment. That's the epileptic encephalopathy portion of this. Onset is usually before 8 years of age. The peak onset is between 3 to 5. We do see older children and adolescents, and there are rare case reports of adults who've evolved into Lennox-Gastaut syndrome. Not everybody has read the textbook and has done this the way that they're supposed to, and we always have to keep our minds open to these kids who are sort of on the fringes. Unfortunately, 90% of children with Lennox-Gastaut continue to have seizures despite all of the treatment options that we're able to offer them. 95% or more will have cognitive impairment. The risk of death is 14 times that of their peers. Up to 15% of children with Lennox-Gastaut will have early death. Children don't usually die. Adults die. Children don't usually die. Having a death rate of 14 times that of other children is significant. 50 to 75% of children and families are trying to manage status epilepticus. They have frequent seizures. They can have hundreds a day. And we also see prolonged seizures and clusters of seizures without recovery. And we haven't really made a lot of progress in how to treat this. And there are about 40 to 50,000 cases of Lennox-Gastaut in the US at any given point in time. So how distinct are epilepsy syndromes? I showed you previously the slide of all of the epileptic encephalopathies. We've talked about evolution. And so if we imagine that A, B, and C are different epilepsy syndromes, unfortunately, a number of our children land somewhere in the middle of these and may have a foot in two different buckets. And that's why we can end up with children who have multiple diagnoses. But it is really important to make this diagnosis of Lennox-Gastaut so that we can make sure we're providing good expectations for family, so that we know what medications to use and we know what some of our targets for treatment should be. There are a lot of challenges. When does Lennox-Gastaut start? It doesn't usually start with that first seizure. It evolves over time, and so we always have to keep our eyes and ears open to this evolution. Most children have other seizure and epilepsy types prior to that evolution to Lennox-Gastaut. But who should we worry about? When I see somebody who comes in with seizures, how do I know that that child's going to evolve into Lennox-Gastaut? We still don't really have good answers to this. Sometimes with a genetic diagnosis, that can be clarified for us, but many times it is not. Treatment. So I have a long list of treatments here, some of which have good evidence, some of which don't have such good evidence. The ones that are in italics are the ones that are FDA approved. The reality for our patients with Lennox-Gastaut is that most of our patients are treated with all of these medications. It really is not only an odyssey of diagnosis, but it's an odyssey of treatment as well. Unfortunately, there are no comparative effectiveness trials in Lennox-Gastaut, so I cannot tell you which medication may be better than another medication because we simply don't have those comparisons. One of the things we always have to keep in mind is surgery. Many epileptologists don't think of surgery in Lennox-Gastaut because of the generalized findings that we see on EEG. But for patients who actually have focal lesions on their MRI, surgery can lead to seizure freedom. And there are some case series where the seizure freedom rate is as high as 60%. So this is something that we need to be looking for. We do need to keep in mind that this is an option for only a small percentage of children, but we need to identify these children, and we need to identify them sooner rather than later. This is a proposed treatment algorithm. One of my colleagues at Nationwide put this together, Adam Ostendorf, and I think it's really a great picture of the odyssey that you guys are living through. We have this diagnosis, which often takes a while to get there. You're usually on multiple medications by the time a diagnosis of Lennox-Gastaut is made, and so we add in adjunctive medication, which just means add-on therapy. We can identify a small percentage of children that go to surgical evaluation, and they may require resective surgery, or sometimes we say this may reduce your seizures but not lead to seizure freedom. The only place on the slide you see seizure freedom is here with resective surgery. I think the vast majority of our families with Lennox-Gastaut are in this cycle right here, where we try a medication, we don't see benefit, and we try it again. And we just keep going around in this cycle. And this is where most of us are stuck right now. This is their recommended list of preferred medications. I've already shown you a slide that had about 3 times as many medications on it. I think the reality is we end up trying all of these medications. And what I often tell families is the question isn't whether you want to try this medication, the question is which one do you want to try now, because we are probably going to work our way through all of these medications. And we need to make those choices based on perceived benefit as well as the concern about side effects. Sometimes side effects are a good thing. If we have a child who's not eating very well, it may be beneficial to put them on a medicine that increases their appetite. Sometimes side effects are things that we really need to avoid. And so really the question is, when do you want to do this, not do you want to do this? We know that Lennox-Gastaut syndrome is so much more than seizures. These are the results of the LGS Foundation Caregiver Survey, which I'm sure many of you have participated in, and I'm sure our families have seen this. It's not just seizures. We see sleep disturbance. We see injuries. We see developmental delay. We see kids who are not making progress, who are using wheelchairs, who are hospitalized at least once a year, who require G-tubes. This is so much more than just seizures, and we need to make sure that we're looking at the whole patient and that we're improving all of these things. I will say, as caregivers, you created priorities, which I think are incredibly helpful. And seizures are at the top of that priority, seizures and safety. But all of these other things, I'm sure, are a pretty close second and are things that we should not be ignoring. One of the things that we would be remiss to not talk about is death in Lennox-Gastaut syndrome. We know that our patients are dying. Major causes of death are SUDEP, sudden unexplained death in epilepsy patients. We've made great progress in this area in the last 10 years in talking about this. I very rarely run into a neurologist who denies that this is happening anymore, but the reality is there were many neurologists who did not think that this was an entity. We know that it is. I think this drives a lot of things that families do, whether it's sleeping with their children, seeking crazy alternative treatments, which drives us as well. We do a lot of crazy things. Resective surgery and wacky diets that we do are really kind of out of the box and crazy. And this is what drives it. We see children dying of status epilepticus, injuries from seizures. My office is the most dangerous place to have a seizure. I have a hard concrete floor, and it is not a safe place to have a seizure. The respiratory events from either secondary to seizures or difficulty swallowing, sometimes secondary to medications. Again, children with Lennox-Gastaut are dying more often than other children, and we need to make progress in this area. So I'm going to come back to this picture because I think this is the one that you need to keep in the back of your mind. I think this really summarizes all of the things that we've talked about today. The one thing I didn't talk about is that we do know this evolution, and there probably are some opportunities for us to intervene and prevent the evolution into Lennox-Gastaut. This is an area where we haven't really done as much research as we should have. Are there more effective treatments to stop the evolution into intractable epilepsy? If we treat West syndrome better, can we stop this evolution into Lennox-Gastaut? There are some specific disorders such as tuberous sclerosis where there's trials right now looking at starting anticonvulsants at the first sign of EEG abnormality instead of waiting for a seizure to see if we can prevent the progression into West syndrome and Lennox-Gastaut. These are wonderful ideas. We need to expand on these ideas. While we do need research in Lennox-Gastaut, wouldn't it be great if we could intervene with everybody before that so we didn't actually get to that point? And that is my hope, that we get to that place at some point. So I'm going to end there because I think there are more people who have much more to say who are experiencing this every day, and they are truly the experts.
So we couldn't agree more with you, Dr. Knupp. It's a horrible business model, apparently, to want less LGS. We want to put ourselves out of business, but we want to not get to that point where the kids are diagnosed with LGS and then their chances of seizure freedom or having a normal life are so low. So thank you for that introduction. That's the medical side of things, and so we're going to move now into hearing what it's actually like living with this. And with that, I'd like to introduce our moderator, Kim McCleary, who's been absolutely wonderful to work with as we've all gone on this journey. She's going to take us through how this meeting is going to work and what it's all about. And there's no person that I'm more happy to be working with on this. She's been very kind and patient and compassionate with all of us as we've cried and cussed and yelled and screamed and gotten over it. So thank you. Kim, come on up. She's our moderator.
Thank you. Good morning, everybody. It is such an honor to be with you today. I don't know, is that sounding weird? Like I'm in a tunnel or something? Maybe Ivy can work on that, or do you want me to go up here? Let's see. All right. I'm afraid we'll get feedback if I walk too close to this. She's like a little rabbit that
skips across those chairs back there. Is that better? Great. Okay. So, as I said, it's been truly an honor to work with Christina and Tracy and the team and others that you'll meet up here in just a moment as we've prepared for today's meeting. And thank you, Michelle and Kelly, for your really helpful presentations that give us some context to think about the next part of this meeting that is really all yours. And before we kick off this next part, where you guys are the stars of the show, I just want to share a little bit of information in terms of kind of an orientation to help you understand the meeting structure and why we've set it up this way, because it's very purposeful and intentional. So for those of you who are here representing yourselves or your loved ones with lived experience with the DEEs and LGS, your name tags with that little white expert label are intentional, again, to remind you that the expertise that you have is what we're all here today to hear. So we've kind of flipped the script on the kind of meetings that most of us go to, where you've got a couple people with lots of letters behind their names, and they have the expert tags on, and you're just the passive audience. But today, we've reversed that. We heard some opening remarks from some experts in their fields, but you guys are the experts in your fields. You're the one who know what DEEs and LGS are like to live with every minute of every day. So at this point, I'd like to invite the first group of panelists up to the stage while I just finish up this orientation part. To help get this dialogue started, we've set up this meeting in kind of two pieces, and we will have two panels of your fellow experts who are going to share their experiences. And let me just tell you what a courageous act this is, not only in terms of sitting up and kind of being the first to speak and share their truth and their stories, but the weeks of preparation that have gone into these remarks. Tracy talked about the armor that all of you wear as coping mechanisms to get through the horrific experiences that your kids and your families go through, and they've had to take that off and be exposed for the last few weeks as we've kind of put them through the paces of crafting their remarks for today. So we'll thank you, as Tracy said many times today, but wanted all of you to know this isn't just an off-the-cuff sort of impromptu thing. They have really spent a lot of time on this. So first, we're going to focus on what it's like to live with LGS and the DEEs, the symptoms, the daily impacts, the limitations they impose, and which of these impacts sort of are the most highest priority for you as you think about what treatments would be beneficial. And then second, we'll have another panel come forward, and we'll dig into the treatment of DEEs and LGS, and another challenging picture from what Kelly shared with us. Again, starting with the panel of experts. But in between those panels, we're going to break this open. We've got a number of discussion questions. We're going to have mic runners. You're going to, signal that you've got something to add. So this is your opportunity to build on the kind of the invitation that the panel creates to open up what is tough subject matter, and we know that. So just feel the agency and the empowerment that you have in this room today, as Tracy said, to be heard by not only the FDA, but representatives from life science companies that are researchers and developing clinical trials and clinical trial protocols, that are preparing packages to submit to the FDA about what they'd like to do next to help bring better treatment options to the market. So take that opportunity, and we hope this will be your invitation to participate with us in the discussion. And with that, it's my privilege to introduce our first courageous panel, and Nicole Salazar is going to lead us off with Jeremiah's story.
Hi, good morning. Hi, my name is Nicole Salazar. I am here representing my warrior, Jeremiah Salazar. 7 years ago, I was pregnant with our baby boy. We weren't sure of a name. It wasn't until we met him in the NICU nursery that we decided on Jeremiah. Through my pregnancy, my husband and I were excited. We fought over if he would wear a UCLA or USC jersey matched with cute little Converse shoes and a hat. We even joked about which one of us would be the first to get kicked off the field as we watched him play sports. We envisioned teaching him how to ride a bike, how to hill bomb off a skateboard, and many other joys that we enjoyed growing up doing. Never did we imagine none of this would become true. Jeremiah spent 16 days in the NICU. I did not get to hold my baby. I barely got a glimpse of him before he was rushed off for oxygen, a NG feeding tube, and some tests to determine if he had a blood infection. I slept in the NICU waiting room for 16 nights to be able to breastfeed on demand. I didn't have a room nor a bed. The hospital was full. I slept on a chair. I had no physical support as my husband had to stay home and care for our other 2 children. It was at this moment I realized that our journey was just beginning. Our son Jeremiah began having infantile spasms a few months after being discharged. This was his first DEE. Jeremiah started having hundreds of seizures daily. He has 6 different seizure types today, from tonic-clonic, absence, tonic, atonic, myoclonic to non-convulsive status seizures. These seizures cluster relentlessly and give his little body no time for recovery or relief. At age 4, we transferred Jeremiah's care to Children's Hospital of Los Angeles because our local hospital was not equipped to care for him. It was there at Children's Hospital that Jeremiah was diagnosed with LGS, and they aggressively formed a plan for treatment. Jeremiah and our family quickly learned that CHLA would become our second home. That same year that we transferred care, Jeremiah had several surgeries that included a VNS, a vagal nerve stimulator, and a feeding tube right after his 4th birthday in hopes of providing better seizure control and to combat the loss of appetite from the side effects of the medications. I was promised this would be temporary. We spent most of that year in the hospital to gain control. It was such a hard year as we were away from his siblings, his father, and all of the rest of our family. Between age 4 to now almost 7, we have spent many days inpatient on the EMU floor, many EEGs, several MRIs, and a few CT scans are under his brave little belt. I could speak about our story and journey with epilepsy, LGS, forever, but today I am here in front of you to not just be my son's voice, but to be the voice of all others who need to be heard. As much as I would love to have brought my son today so you could put a face to this battle, I was unable to do so because of the level of care needed, the sacrifice and consequence it would take on his health. Our families face many challenges because of the seizures and their impacts. They make our lives unpredictable and unstable, yet in another aspect, they are filled with routine and must be schedule-orientated because of school schedules, medication reminders, medication refills, feeding tube schedules, the therapies such as OT, occupational therapy, PT, physical therapy, SLP, which is speech therapy, and ABA, Applied Behavioral Analysis Behavioral Therapy. And if you don't know these acronyms, consider yourself blessed. As Jeremiah is almost 7 years old, our battle has evolved. My focus has changed. Our main focus is now quality of life. Jeremiah experiences disturbances in his behavior, currently still has loss of appetite, so therefore he still has his feeding tube. Depression, anxiety, and moments of rage. He has developmental delays, his second DEE. Shows regression in his education, personality, motor skills, and mobility. His physical growth is stunted. My baby is struggling. This is where we could use your help. Our children require 24/7 care. We need access to durable medical equipment, such as gait trainers, wheelchairs, adaptive strollers, feeding tube and medical supplies, shower chairs, timely prior authorizations for medication refills such as Epidiolex. We need to be respected and as part of the care team and be heard. We know our children best. When having a medical fragile child, we should be able to explore any and all routes possible without fear of consequence or retaliation, obviously within reason. I ask of you to please consider working with the DEA for the descheduling of cannabis so that research can be done and that we can explore cannabis as another form of treatment. Let's leave no stone unturned. As hard as this journey is, our children are our greatest joys. I stand in front of you to show you a glimpse of our daily fights and battles. I have tried to give you a glimpse of what it's like to be in my shoes, but the truth is, unless you live it, no words could ever tell you the burden yet honor it is to love someone with LGS. I thank you for your time.
Good morning. My name is Jennifer Griffin, and I'm from Santa Barbara, California. If you were to meet my son, Theo, your first impression might be, wow, this is a beautiful young man with an athletic physique. He must be a star athlete with a lot of girlfriends. Then, within a very short period of time, seconds probably, you'd realize that this 17-year-old young man is more like a 2-year-old toddler, maybe even younger than that. Can he respond to simple commands? Nope. Can he say mom or dad or any other words? Nope. Can he feed himself, dress himself, toilet himself, bathe himself, walk without assistance? Nope, 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 and nope. Theo is not your typical 17-year-old. He's not dating, filling out college applications, driving, or getting into trouble with his crew. He's not even consistently sleeping through the night yet. You see, Theo has Lennox-Gastaut syndrome, or LGS. Theo's LGS journey began on October 18th, 2002, with his first tonic-clonic seizure. I was holding my beautiful 4-month-old baby in my arms when his back arched, his eyes rolled back, and he began to convulse. After rushing to the hospital, we began a series of tests that culminated in the words, infantile spasms. We soon realized that the little crunches he'd been doing for a month were actually seizures. My only thought at that time was, oh my God, he may never drive a car. That was about as far as my imagination would take me. But little did I know the odyssey that lay ahead. By the time Theo was 5, he had received the LGS diagnosis. He still wasn't walking or talking or sleeping. For many years, he'd wake up every night for 2 hours or more. I would lie there beside him, waiting for the inevitable seizure that would knock him out for a few more hours of sleep. And I'm ashamed to admit that sometimes I was grateful for that sleep-inducing seizure. We moved through our day in a fog, often stumbling and falling from sheer exhaustion. He carries many scars to remind us of those moments. Around that time, his dad and I were separating, and I was feeling alone, isolated, and depressed. We lived in a new city with no family or friends nearby. Theo's 2 older sisters were excellent mini caregivers, but I wanted them to live their own lives without always having to make sacrifices to whatever chaos was brought on by the seizures. Little adorable Theo soon grew into the muscular, hairy dude that we have today. He finally took his first steps at the age of 6, but he still staggers and falls often, requiring a wheelchair when outside the home. He also needs 2 helmets, one with a face mask and one without. The scars on his face and his broken teeth, courtesy of nasty drop seizures, prompted those important purchases. Theo explores his environment through touch. He loves to grab anything within reach. The number of broken bowls and glasses are countless. This man-child has been gifted with superhuman strength and quite often leaves a path of destruction. I don't own anything of real value. As long as no bones were broken or blood was shed, I figure it's all replaceable. As for treatment, we've practically done it all. Multiple meds, ketogenic diet, vagal nerve stimulators, CBD, etc. But still the seizures come. And as Theo gets older, we have to consider his safety more and more. His dad and I co-parent well together and have a friendly relationship, thank goodness. Because as much as I do alone, I also get the occasional break so that I can come here and talk to people like you. What do you need to know? Well, because of seizures and the other physical and cognitive impairments, Theo isn't safe, and he never will be. He needs capable caregivers, but pretty soon that person won't be me. I often say Theo is getting older and stronger, and I'm getting older and weaker. Just this year, while getting him out of the bath, he suddenly leaned into me for a hug. I wasn't prepared, and slippery Theo fell on top of me, sending us both into the toilet. It came off its foundation and split in two, sending water pouring through the bathroom. I had landed hard on my back and ended up with a bruise, but it could have been so much worse. What if I had landed on my head and been knocked unconscious? Now, that's not the first time he's taken me down, but it was the worst. He's also lost his footing and gone through a window. With sheets of glass surrounding him, there wasn't a single cut on Theo. His guardian angel was working overtime that day. Broken toes, fingers, and teeth have also been part of our lives. Theo doesn't even cry or indicate any type of pain, so usually we discover injuries only when we look closer and see a swollen body part or a crooked body part. I have no idea to what degree he's feeling the pain, and it breaks my heart to think that he's hurting or suffering. Our LGS loved ones, or warriors as they're often referred to, deal with so much and have so much to give this world. But they deserve so much better. They deserve a brighter, safer future. Thank you.
Good morning. My name is Christina Saninocencio, and I am the sibling of a 31-year-old man with LGS named Michael. I'm also the founder, like I mentioned earlier, and executive director of the LGS Foundation. I'm happy to be here to offer my perspective as the director of the foundation, but more importantly, as a sibling. Michael's seizures started when he was 3 years old, and they came seemingly out of nowhere. I remember that first seizure very, very, very vividly. I was just 7 years old when it happened, and I thought that he was having a heart attack, and I thought that he was going to die. I didn't know what a seizure was. I'd never seen a seizure before, and I just remember hugging my older brother, Ricky, in the hallway outside the bedroom where it was happening, saying, hey, I really, really, really don't want Michael to die. Over the years, the trauma of watching Michael have hundreds, thousands of seizures, and watching his little body seize uncontrollably over and over again, watching his head go through walls, through tables, and everything else, impatiently waiting with my mom for the ambulance to arrive when he was going into status epilepticus, was devastating, and it still is traumatic to this day. I was left over and over again with neighbors and friends of my family because my parents had to literally just get up and move to the hospital with my brother. And that trauma, again, was horrific. But on a positive note, that's where a lot of my passion is fueled from, to help others with LGS. And I know that everyone here in this room feels the same way, that our lived experiences have shaped us into the people that we are today. And thank goodness that today Michael is actually doing relatively well in terms of seizure control. He's considered one of the lucky ones. He can actually read and write at about a first grade level. And he's verbal and can tell us how he feels. And he can do daily tasks like bathing sometimes when pushed and brushing his teeth without assistance. But that doesn't mean that we've won the LGS battle. As his seizures dissipated, behaviors emerged. And behaviors were never something that our family was told about. We could deal with seizures, sure. But the behaviors, we were never told about. And those were really horrible. When a family first receives a diagnosis of epilepsy or LGS, their care team usually focuses on stopping the seizures as best as possible, which they should. but they may not tell you about the other problems that a person can face, like those behaviors. And when they emerge out of nowhere, you are once again faced with a new challenge you didn't expect. Today, Michael lives in a group home that can handle his behaviors. He's happy there and attends a day program for adults with disabilities where he learns life skills and has the ability to socialize with his friends there. We are so proud of Michael and are happy that he's doing relatively well now. Now, if only the behaviors disappeared, we'd have one less thing to worry about. But that is the unpredictability of LGS, and as many in our community will attest to, the only thing that is predictable about LGS is the unpredictability. Thank you.
Hi, my name is Kathy, and I live in Florida. I was waiting for Tracy to put the signs up. If you look behind me, those are the hands of my son, Matthew. If he were here with me today, he would be a handsome 23-year-old. Consider the imprint his hands made on that piece of paper for me to have and always cherish. Matthew made that same imprint on the hearts of the people that knew him in his 18 years. Oh my goodness. Matthew passed unexpectedly September 13th of 2013, 3 days before he was to turn 18. As a newborn, Matt's seizures presented as stretching episodes. You know, those adorable little baby stretches where the baby will arch their backs, make a tight face, eyes closed, and raise their hands to their face as their body shakes. This began on our first day home from the hospital. Matthew, being my third son, I recognized these movements were unusual, happening every 2 minutes, all day long. These were not cute, and they were not going away on their own. For 2 months, the pediatrician assured me that nothing was wrong and politely informed me that I was an apprehensive mom who forgot what babies do. Thankfully, we lived near a world-renowned children's hospital, so we packed up and headed to the ER. I needed another opinion of my very real concerns. I brought along a video of Matt's stretching episodes. I was told that these were seizures and that Matthew was then admitted for a week of testing. At the end of our stay, we sat in the office of the chief of neurology, who gave very little explanation other than a confirmation of the diagnosis of generalized seizure disorder and the fact that medication would be needed to control his seizures. That control was fleeting. Today I know that those stretching episodes were actually a case of undiagnosed infantile spasms. I also know that infantile spasms are an emergency and that if diagnosed early enough, combined with the appropriate frontline medications, it is possible to stop infantile spasms from progressing to other catastrophic childhood epilepsies like LGS, as it did in the case of my son. I work through the Infantile Spasms Action Network to raise awareness so that diagnosis occurs and treatment begins with an urgency so that we can achieve that best possible outcome for our children. Matthew's seizures continued to worsen as he grew. They became more intense and they followed no pattern. During those terrible days, back-to-back seizures, I had hours to sit beside my son as he experienced and recovered from tonic-clonic seizures and the incredible amounts of rescue medications that had to be administered. I used this time well for online researching and reading all I could about childhood epilepsy syndromes, including LGS. When our doctor told us that a more specific diagnosis would not change the fact that the seizures needed to be controlled, I knew it was time to search for a new epileptologist. I actually found a specialist who was interested in a team approach, offered a fresh perspective, and valued Matt's quality of life. LGS was confirmed by our new specialist when Matt was 14 years old. Matt's journey continued. There were countless meds, sometimes in combinations of 4 and 5 at a time, a corpus callosotomy, which only gave Matthew 20 days of 0 seizures until they returned with the added challenge of respiratory distress with each seizure. He was still having unrelenting nighttime tonic-clonic seizures, and many nights the seizures clustered nonstop. For 18 years, I slept next to my son, always keeping a hand on him, so I could feel him breathing and react quickly with the rescue medications if they were needed. Sorry. This was a way of life which all parents with severe childhood epilepsy syndromes like LGS recognize. Although medical professionals had assured me that a person cannot die from a seizure, during an online search, I came across sudden unexplained death in epilepsy. This was well before it was talked about. What I learned through real-life experience is that SUDEP can and does occur even with all the preventative measures a parent can think of in place. In the early morning of September 13th, 2013, Matt had been constantly monitored by a nighttime nurse. He appeared to be sleeping peacefully on his side. The one night I decided to sleep in my own bed. No obstructions, and he had no preceding seizure. A rare night for him. Yet something felt off, and we quickly realized that Matthew was not breathing. Immediately we began CPR, and we called 911. As the paramedics arrived, I watched as every life-saving intervention was attempted, and he was taken away by ambulance. The final fact that I learned about SUDEP is that there are cases where patients who are in epilepsy monitoring units who have immediate intervention like Matt, and efforts fail. We don't win if we live in fear. My hope is that research brings answers, earlier diagnosis, better treatment, and sooner prevention that is effective. Even with that, life is not a guarantee. So let's live how Matt did, happy and content, laughing and smiling and loving. Thank you for listening and wanting to know about the impacts of LGS. My wish is that no other parent would have to miss a child that they live to protect. Thank you.
To our panelists who worked so hard over the last several weeks to compose your stories and share them with us, thank you. Thank you again to our remarkable panelists. I'm going to invite you to return to your fellow expert tables so you can participate fully in the conversation. That was a lot, and there's a lot more to come from all of you on these same topics. Nicole shared how Jeremiah's condition was apparent from the very first minutes after birth. Well, Kathy's experience was a bit different. She encountered a physician who didn't think anything was wrong, and we heard Dr. Knupp refer to the diagnostic process as an odyssey. Just like to see, by a show of hands, how many of you got kind of an answer, or it was obvious and apparent that there was something wrong with your child? And for others, it was a longer process. Odyssey would be the right word, maybe. Yeah, it looks like that is the more common experience, at least here in the room. We've got 2 mic runners. Yes, I guess. Next style. Is that better? Okay. A
I'm sure there are other experiences about what that early stage was like, how you as a parent recognized something was wrong and what you had to do to get appropriate care from the medical system. Invite somebody to join. We've got mic runners here who are going to make sure that we've got the ability to hear you. Great.
Hi, my name is Brittany Brown, and my daughter is, well, she's out there watching The Lion King. She's 10 years old, and she has LGS. She was born on a sunny day. She came out easily, and I truly felt the connection between us. A 30-minute labor turned into this lifetime of love. I had been in a research study that studied why Black women have miscarriages, and so I had an amniocentesis, and she had been tested and studied, and they told me everything was great for her, and I was going to have a healthy, happy baby. And she was born. She was not your typical baby. She didn't cry much. She slept through the night, and she always looked at me so lovingly. When Amari was 2 months, I took her in for a routine well visit where she received her vaccines. Well, who knew this would be the day that would change both of our lives drastically? Before we left the pediatrician's office, Amari started to cry. It wasn't from the poke of the medicine, but it was from a spiking of 107 fever. Immediately, life started to spin and they ripped her from my arms. The ambulance ride seemed so surreal, and the once loving eyes of my precious baby just rolled back as the sirens began to blare. DOA is what I heard the driver radio to the hospital, and walking behind them, I felt like a zombie, just trying to hold on to anything of her hot body. What happened? They wheeled her away as they sent the chaplain and nurses to slap me back into reality. They asked me questions that I couldn't comprehend, and they called my mom. I begged and pleaded to see her, to hug her, and to be by her side, to feel the connection that we had. I just rocked her with tubes down her throat against my chest, and I started to cry, and I heard the faintest noise come out her tube. Her toes started to move, and her eyes twitched. The monitor slowly beeped. She felt our connection, and she came back to me. So let's fast forward. She was diagnosed with infantile spasms. We knew this was a temporary condition that was going to lead into a lifetime diagnosis. I remember the doctor just shaking his head, took my hand, and said, "She's going to die. They don't live long with this condition. Medicines don't work." I laughed, kind of like the Joker's sinister laugh, because we cheated death, and she came back to me, so we are invincible, right? This little baby started to have hundreds of seizures a day, and there was nothing I can do. I couldn't help her at all. I remember having to choose between her being sedated and having less seizures or taking less medicine and having tons. She failed every medicine. She went unresponsive on Depakote, Topamax killed her kidneys, and Sabro took her vision all before she was 1. Since that fateful day in October 2009, she was doomed. And at 3, she was diagnosed with LGS. I felt like I had signed her death certificate. All the doctors said the condition would kill her, but it wasn't the condition, it was the harsh medicines that signed that certificate. Lamictal took her voice, steroids caused diabetes and breathing issues, and the keto diet, it works, but her kidneys don't. She never drank, but her liver has aged like she was an alcoholic, and her kidneys stopped processing, and we won't talk about her breathing. She is 10 now, and although she is still alive, is she? Through the hundreds of trips to the hospital, 2 comas, 5 life support scares, and 27 surgeries, she's still here. Wow. Having every bad side effect and allergic reaction, she's still here. But you see her shell, but she is that because the medications took my baby. It wasn't the condition, it was the high dosage of medicines that was given to her as a baby to get seizure control. Recently, we found out that a medicine called Briviact has done more harm than good and caused the chemical gastritis. Well, just stop the medicine, right? Well, you can't just stop a seizure medicine without interrupting the overall chemistry of your child. It's a shock to their system. But as I sit on the other end of a phone with the option to keep the seizures at bay with this medicine or furthering what they think is cancer, you end the medicine, right? These are the decisions that LGS parents have to make every day. Take a medicine and interrupt their whole lives. Add a medicine and interrupt their lives. Keep a medicine and kill them. No parent or child should have to face this, but this is our LGS reality. Thank you.
A lot of things in that story, Brittany. Thank you for telling it so beautifully and well. Let's break it down. Let's go back to those early days. And it seems like you were told your child's going to die. I've heard other parents talk about the fact that the doctor said kind of the opposite. Oh, this is really nothing. They're going to grow out of it. I see heads nodding. So you're kind of caught between these two very different ends of, dire predictions, and it's really nothing at all. Let's hear just kind of quick little vignettes, if you will, about what that was like. Nicole?
For us, Jeremiah,
You want to wait for the mic?
For us, we were told that we were going to bring home this baby. We didn't have the feeding tube. He graduated, and we were going to be fine, and he was going to outgrow this, and everything was going to be perfect. When the infantile spasms started, I was told they were episodes. They weren't infantile spasms. Our neurologist refused to hear me. When I started doing my own research till I was blue in the face and couldn't read anymore, I was like, no, this is what they look like, and this is exactly what they look like thanks to YouTube. And again, when we finally had a seizure on EEG, it was dismissed. He'll outgrow it. Nobody mentioned SUDEP. I went home again and researched, and that came up, and I was like, why was this not brought up to me? Like, what happens if I would have lost him? And there has been 3 cases where I have found Jeremiah face down in his pillow, barely shallow breathing. And I really feel if we wouldn't have walked in on those nights, he wouldn't be here. Jeremiah doesn't like to sleep with me because he's persistent of being a big boy. So he sleeps with his sister. I'm sure Christina could vouch for this. As a parent, my worst fear is for her to find him. I'd rather find him. But it needs to be brought up. It's not a comfortable conversation. It's not something us as parents want to hear. It's not something as a neurologist or epileptologist that you probably want to go over. But it's something that in the early days of diagnosis you should mention. And it should be spoke about. And that way, because there is monitors, there's things to help. And like Kathy mentioned, there, even with some of these things, it may still happen. But at least we're aware of it. That was just brief.
Yeah. 2 themes that keep coming up are the sort of self-education that you have to do, that your expertness, if you will, coming from, watching YouTube videos, reading books, reading textbooks, scouring the internet are kind of part of the role as parents and advocates for your kids. The other thing is just the constant vigilance and the state of high anxiety that you have all described in terms of caring for your children.
Would it be okay if I answered and then we'll go? Just to go back to the evolution, so my daughter's 26 now. She was totally typically developing till she was 2.5 when she had a seizure, and by 3 it was hundreds of seizures a day, 6 different types of seizures. And in the beginning, you're just, what is it? What is this? How do we stop it? What is it? And at some point you ask what causes it, but then after a while, you aren't even really focused on that. And 25 years ago when this first started with my daughter, seizures don't damage the brain. You can't die from epilepsy. And thankfully, we don't need to know what causes it in order to stop the seizure. So they were very, very non-aggressive about it and nonchalant. She'll outgrow it. It's not a big deal. She just has to take medicine. And, when you would point blank ask, can she die? They'd say no. And I think that's really is shifting now. But there comes a point, and for us, it was probably about 2.5, 3 years in, where we switched from, oh, how do we stop it, to, oh shit, how do we live with this? We all knew I was gonna cuss today, I'm sorry, just, sorry, Mom. How do we live with it? How do we live with it? And, she was going hundreds of seizures a day. She would go into status epilepticus, this non-convulsive status where she would just sit and stare and twitch and blink. And the longest one went for 4 days because nobody believed that that was a seizure. We knew more about what was going on with her than the doctors did. And then there came an additional shift after sort of how do we live with it, of just apathy, like these periods of apathy. We're not going to do anything, we're not going to try anything, this sucks, to, well, we have to try something again. And, we can't give up on our kids. We've had doctors give up on our kids. We've had teachers give up. I mean, we don't even really fit into the community because our kids are having so many seizures. So we don't go to epilepsy camp because our epilepsy is too bad, and we don't go out in the world because they have seizures everywhere. And if there was a concrete fireplace in a 10-mile radius, my kid's head would find it. So it is this journey, and there is this sort of, now that she's 26, sort of across this lifespan to consider that it changes depending on the age of your kid. There is definitely this evolution. I just wanted to comment to that, and thank you.
Let's let Jamie answer, and then I do want to go
Okay, and
back
we have a lot of other hands that have been up
and
for a
pick
while.
up the thread about seizures. It's such a prominent feature.
Okay, so my Andrew is 12, and he was born with a repeat C-section because my daughter was born C-section, so nothing unusual there. And at birth, like a day after they're born, they do the hearing test. Well, he failed his hearing test 5 times before they decided, maybe you ought to go to Dartmouth and have his hearing checked. He had hearing aids by 2 months of age. Everything seemed totally normal and fine, except for he couldn't hear me. I could live with that. That's not a big deal. So he was having these episodes of what the mice people or the multisensory people were telling me were sensory breaks. It was actually infantile spasms. He was actually having these jerks, and they weren't related to the sounds that he was hearing. And those weren't diagnosed until he was 11 months of age, when we did an EEG, and he was seizing 8 out of 10 seconds. So that's how we found out.
Kathy.
My name's Maggie. My son Ryan is 14, and we're from California. And we have sort of a different story. I didn't see Ryan's cause of LGS up on the etiology list, and I really want to share it because I've been hearing from a lot of, not a lot, but quite a few different people that there are kids like Ryan. Ryan was born typically. At age 22 months, he developed leukemia, and he was treated for leukemia for 3 years, relapsed 10 days off treatment, and had to have what was called salvage therapy, total body irradiation, lifetime max dose, and a bone marrow transplant. And that was at age 5.5. And after that, first of all, we were surprised Ryan survived. But he actually thrived. He thrived. He actually learned, even though he had developed developmental disabilities from his treatment and learning disabilities, he was actually learning. He was he was like at grade level with supports and service and a one-on-one aid, and I was creating supplementary materials for the teacher and very actively involved. This went on for about 3 years. Ryan did have one seizure when he was in treatment for leukemia. It's not unusual for some of the leukemia kids to have isolated seizures. Anyways, they're starting to find out that, I don't know if it's just the leukemia bone marrow transplant kids, or if it's also like brain tumor kids or other kids with different types of pediatric cancers that are starting to develop LGS. But no one's talking about it. And this is, or not enough people are talking about it, actually. So Ryan about 3 years after his transplant, started having, we suspected, absent seizures. I took him to UCLA, and same thing, I struggled. We saw, I mean, I'm so picky because Ryan was treated at City of Hope for his cancer, so I'm very picky when it comes to doctors, and I made sure he was seeing the head of neurology, pediatric neurology, and it was ridiculous. It took over a year to diagnose him. I had to convince the head of neurology that Ryan was having seizures. Convince him. Then he finally, oh, you're right, after like, you know, having us as an inpatient, and doctor was never available. Also, I want to say that when we were pediatric oncology, a pediatric oncology family, we were bombarded with support and information. It's sort of like, hey, welcome to hell. Your kid has cancer. Here's all this information. We have Child Life. We have a neuropsychologist. We have so many support services. It's just amazing. And then when Ryan developed epilepsy, nothing. I asked about the keto. Doctors at UCLA said, oh no, that's really hard, you know, and you don't want to do that unless everything else fails, which is ridiculous because I know a lot of pediatric cancer families who are successfully on keto, and eventually they were the ones, not the neurologists, who helped us to eventually get my son successfully on a ketogenic diet for 2 years now. The support services are not there in the epilepsy and specifically the DEE community, and they need to be there. They're there for pediatric cancer patients. They should be there. I mean, they can be developed. Information's important. I did not get any information. Ryan started with the absent seizures, which turned into complex partials. By then, I was really upset with UCLA, and I transferred all his care to Stanford. We were driving to Stanford and flying to Stanford. He's still there, but I'm going to transfer his care now because I'm not getting satisfactory care. Up there, Ryan kept having complex partials. As he approached puberty, he started having convulsive and I guess drop seizures. I don't know. Anyways.
You know, Maggie, I want to pick up on that point and hear from some others. I think you brought up a number of really important points in terms of having to be so empowered and have the kind of education that you have to do kind of in real time about these seizures because the information and the support isn't there.
It's not just information. Can I just say one more thing also? Because I begged from the beginning for CBD and for keto, and I was told no. So we did this on our own, a whole foods-based approach to keto and CBD. We did Charlotte's Web. We paid for it out of pocket. Once Ryan started Charlotte's Web, he was completely 100% seizure-free for 3 months until I forgot one of his doses one morning, and then everything just like spiraled out of control. Then he was having over 100 seizures a day eventually after that, and it wasn't until he started Epidiolex. He has like a 90% reduction in seizures.
That's great.
So I really think that it's really important for the FDA and drug companies to use CBD, Epidiolex, and less invasive forms of treatment as frontline therapy and not last, you know, because my kid could have potentially had better seizure control in the beginning and it would have never developed into LGS if we would have gotten what we asked and if we would have had more information and better tools.
Yeah. I think everybody here would agree with that early intervention is the goal and where we need to move to prevent some of these downstream consequences. One more, and then I want to take a look at the seizure issue.
My name's Helen Steinberg. Our son, Jason, well, I had a difficult delivery, not delivery, but the I can't think what it's called, when you're in labor. The labor was difficult, sorry. And right after he was born, he stopped breathing for 3 seconds. It was a very short time. They took him away immediately to an intensive care nursery. I had complications, so I didn't see him to touch him until the next day. Jason will be 39 on Thanksgiving this year. Our story is a little different than others. That first 3-second not breathing, I'm certain must have been a seizure. They said they monitored him, nothing was wrong. At 3 months, well, we took him home, and we had a baby nurse because of my complications. I couldn't really lift him the first week. And the baby nurse said, something is wrong. She's handled many babies. She had 3 or 4 of her own, and she said, he's too good. He's not startling at all to the telephone or the vacuum cleaner. Maybe he doesn't hear, but something is wrong. Questioned the pediatrician. He said, nothing is wrong. At 3 months old, when changing his diaper one day, his facial expression changed and he looked like he had mental retardation. I told the pediatrician, he said, 3 months, they don't have full control of their facial muscles. Move on to 7.5 months. 7.5 months old, he woke up from a nap about 8:30 in the evening, and he went for 20 minutes of individual seizures that were there in a second and gone, and then the next one and gone, 20 minutes worth. And by the end of that week, he was in Children's Hospital in Philadelphia, diagnosed with infantile seizures. The pediatric neurologist, I questioned, and you're going to laugh, he said, if it's what he expected it, which was infantile seizures, it would not be an easy road. And he needs to get on medicine quickly. And I questioned whether the medicines would create a problem in his future for reproducing. And he, with a straight face, said, we only worry about that with girls. I guess for lack of knowing how else to handle it with me. We went through the various medicines, the ketogenic diet, nothing was helping him. And when he was 10, he had corpus callosotomy because he did have drop seizures. He was crawling at that point, and he would have drop seizures and break his teeth and all this kind of stuff. And he was evaluated, and they said that they won't stop all his seizures, but they might only stop the drop seizures. And I was like, fine, great, that's the one he gets hurt with. And it did stop. I mean, he went from 9 a day to 1 in a year. At 39, Jason is non-ambulatory, nonverbal, limited use of his hands. He understands, though, understands a lot, and he shows you with his facial expressions. And recently, he also now has a vagus nerve stimulator. He has that for about 3 or 4 years. He's had other medical complications because of being non-ambulatory and because of the seizures. And I have to say we're lucky. He has never been, his seizures have never caused the hospitalization for not breathing. He came close to it this April, but that was an unusual circumstance. But he is delightful. Even with decent control, he still is having seizures daily, but they're very minor. And the neurologist isn't totally concerned about them. He has moved his VNS up to the highest amount that it can be. But he is now showing that he understands more and even doing little simple things to communicate that he has never done before. And just as a cute little thing, he recently was sitting on the front porch of his medical group home, and I had been told when I got there that he didn't have his little nap that he likes to take after lunch, so he might be tired. And after sitting out there for 20 minutes, 40 minutes, something like that, he suddenly turned his head sharply to the left, where the door to the house was. And then he looked at me, and he closed his eyes for longer than a blink, maybe 4 or 5 blinks, and then he opened them and looked me right in the face again. And I said, "Do you want to go in and take a nap now?" And I got the nurse and went in, and she saw him looking at the door. And this was not a normal behavior for him. He was talking to us in the only way he can. But he is a very happy person. He's in a good program with a lot of stimulation, visual stimulations. They tried for years to get him to use a push-button thing for speaking. Obviously, he didn't care about that. He is using it to make a golf ball go across the screen on the computer because it is the visuals.
Yeah.
But anyway, there's a mixture. Our kids are all different.
Absolutely.
Different situations. And I do wonder if, when he was born, if more testing had been done, if at 3 months testing had been done, could they have stopped the progression?
Well, thank you. And hopefully the research is, taking us closer to the time when your son might have been caught earlier and more could have been done early on. I think that's a recurring theme that we're hearing also, is how many missed opportunities there are along the way for something to be caught and addressed more quickly before it transitions. I want to move into the seizures. We've got still, 20 minutes in this session, and we'll come back to you. The seizures, I'm sorry, bumping into you. The seizures are such an important part of this, but it strikes me that the way that all of you speak with such awareness of the different facets of the seizures is important to stop and take a moment to really address, because it's almost as if you talk to Native American people living in Alaska about snow. They have all different ways to describe different types of snow, and it seems from the way that you all are such keen observers of your kids, you know the difference between these types of seizures that, frankly, neurologists and epileptologists take years to study and maybe never see quite the full range that all of you do. I've heard a lot about the drop seizures and the impact of those on safety and the physical consequences of having drop seizures, of the status epilepticus and how those are difficult to manage, the clustering of seizure types. Would someone like to just talk about how you came to understand kind of watching your child and recognizing when you were moving from one type of seizure to the other, since it is a syndrome that evolves with different seizure types? Let me go over here.
Our Elliot had seizures, what appeared to us to be seizures, very early on. The pediatrician poo-pooed it. Finally, I think it was 3 months that we got a neurologist, and the neurologist put him on Keppra, and the seizures kept getting worse, more frequent, and the feedback continued from the pediatrician, no worries. The neurologist saw us once, and over a 9-month period, as seizures kept getting worse and worse and worse, just increased the dose by email. Saw him once. And it wasn't until he was in the hospital for an EEG. The EEG was interrupted. The doctor reading it rushed into our room probably 5 minutes into the EEG and said, "This child has to be hospitalized immediately." And it turned out the Keppra was toxic. We started a foundation focusing on his genetic disorder, and we did a survey, and we found out like 90% of the kids had toxic reactions to Keppra. And we, right, oh, this is SCN8A, so it's not LGS, or maybe it is. He matches a lot of the things. So 90% of these kids had adverse reactions, and when we tried, our doctors who worked with us in understanding our disorder tried to get it published, the data was poo-pooed because it was just family reported. And I'm not sure yet whether there's an official counterindication, but the notion that families have to discover what the adverse effects are and have to continue, like so many of you talked about, these are seizures, they're worse. And a pediatrician undermining it, and even a neurologist being so unprofessional and so unaware and so inattentive. It was infantile spasms, went on for well over a year, and we think there's probably permanent damage from that long period of not only inadequate treatment, but toxic treatment.
Hear from Andy.
I'd like to address your question of how do we get to this point of knowing all of the seizure
Thank you.
activity.
Thank you.
I really think that it's important to mention all the parents in this room, because without the Elizabeths, without the Christinas, who's not a parent but a sibling, without the Sarah and Dales, those are the people that I went to when my son was diagnosed with LGS. I thought I was never going to get to the point where they spoke so eloquently about their children, and now we're here. And I think, you know, not to discredit epileptologists and not to discredit any neurologist, but I think there is a real still mystery behind the LGS piece in the neurology world. And I think we have to really rely heavily on each other. And so for anybody that's watching, I'd like to say, if you haven't made that connection, make that connection, because we're going to be your best support system. Not to discredit what they're doing too, but the blame doesn't go there, I wouldn't say.
I hear you and agree with you, and it's very clear that in settings like this, in the video we saw of the family conference, there is such an important exchange of information that helps all of you be better caregivers and more empowered advocates for your children.
I'm Crystal, and this is my son Jordan. He's 13. Something that several people mentioned, but I just want to piggyback on. We didn't have a difficult time proving that my son was having seizures because he had them in front of doctors and neurologists, but just proving that he was having the side effects from the medications was very difficult, because a lot of times we would get back that, well, this doesn't cause that. And I'm saying it may not on paper, but I'm telling you, he's having more seizures. He's having aggression. He's not sleeping at night. And so I just think that it needs to be something where if a parent is telling you this is happening, we're not making it up. We don't want these things to happen, but this is really what's happening. And we finally just kind of had to take it into our own hands when I think he was on 7 medications and still having seizures at 7 years old. And I'm like, this isn't going to work. And even after asking a university doctor to pull us off of certain ones, we were told no. And so we had to do those things on our own. And so it just puts parents in positions where we have to make decisions that we think are best without the help of experts. And it's
absolutely. Yes. And I think you really eloquently bring up this point of when you're on combinations of medicines that have been studied individually, and you're dealing with your son's own biology, how do you sort out what the disease process is against the backdrop of the medications, the side effects, and the other, complications between those medicines? Go here next.
Hi, my name is Kim Saninocencio. I just wanted to talk a little bit about some of the different seizure types, because in Michael's case, it seemed that every time he got a little bit better control over one kind of a seizure, a different seizure would emerge. And I think a lot of parents have experienced that as well. Some of the seizure types actually had names, drop attacks or absence seizures or tonic-clonics or clonics. And some of them we have no name for. We don't even know what they are. Like, he would have these night terror seizures, and we didn't even know if it was a night terror, like a nightmare, or if it was a kind of seizure. We did end up taking him to the ER for this, and it turned out it was some kind of a seizure. We still don't know what it was called. We don't know the name of that seizure. Also, the status where he's walking around, he's not having a status where he's shaking and having a tonic-clonic. He's just walking around in a state of confusion for hours and hours and hours, and we would call his name, and he wasn't there. He couldn't focus. Again, another ER visit for that. And another thing, when he goes with better seizure control, or if he goes several days without having seizures, his behavior becomes unbearable. He becomes aggressive, he becomes psychotic, and it's extremely difficult for our family to handle that, and we really just don't know what to do. So there's all different kinds of things that are not explained, that there's no answers for.
Absolutely, Kim. Dr. Knupp made reference in her talk to the caregiver survey that is included in the program booklet. And obviously, for reasons we have already heard, such graphic and compelling detail about seizures are your number 1 priority. But Kim, as you just mentioned, the different types of seizures, and it sounds like almost a game of whack-a-mole, where you get one and you're just in this constant chase about these different seizure types that all might require different management strategies. If we could just do some sort of, non-scientific ranking of the different seizure types in terms of the impact on your child's overall health. So I know there's a lot packed into that and a lot of choices you'll have to make as you do every day. But for how many would say that the drop seizures are the most impactful? Okay, quite a few. How about the tonic-clonic being the biggest problem?
I don't know, because I think you throw a twist in there, because sometimes
It's-
people stop breathing during a tonic-clonic, and other times he breathes. So is that worse than the drop where he didn't get hurt, or is that
Yeah.
worse than the drop where he cracks his head open?
All these
I don't
decisions.
think I can pick.
Okay. How about the status epileptic? I can't say it.
Epilepticus.
Epilepticus. Yeah, definitely. Others. What? Just throw them out. Like
Non-convulsive status.
Non-convulsive status. Yeah. I'm sorry. Subclinical. Because of the difficulty in recognizing it and knowing it's happening.
Myoclonic.
Tracy, I've seen your hand up 5 times. I think it, more important than the number of hands, it just shows. And maybe 2 months from now, you might feel that you have to raise your hand in a different spot. It is this very dynamic, ever-changing, as Christina said, the only thing that's predictable is the unpredictability, and it can shift and change. I think the other part of the seizure piece of this is that it's not just the actual seizure itself, but the consequences of the seizure, whether that's the recovery, the postictal period, or the injuries that can occur during a seizure that we've heard so much about. How many of your kids have broken bones as a result of seizures? Yeah, lots and lots. Broken teeth. Saw in those pictures, just pictures of, facial and head traumas. Fractured skulls, anybody? Fractured skull? I'm in that group. Yeah, I mean, it's so much more than just the seizure itself, right? Oh. What's that?
I've had CPS called on me because of injuries that I didn't know about. Like, I think it was Jen that mentioned.
You don't know about the...
Cry. Like my guy.
Oh, hang on.
He doesn't cry. And yes, he's verbal, but he could take a beating. And it's a daily thing. So I mean, I had CPS called on me at one point, and I'm like, and it was because of prior hospital. I did take him that one time he had a seizure, but they didn't catch the fracture.
Wow.
So that opened up another thing.
I want to make sure that we're getting all the people who've been waiting, though. as well.
And
Yeah.
I'm actually addressing the next thing, or let me start again. My son Ben is 21. Very, very briefly, the developmental issues started before the seizures started, and I think this is less uncommon than maybe we've heard in this room. Because he had an autism spectrum diagnosis, his abnormal EEG was not treated because, quote, kids with autism have abnormal EEGs, unquote. When he started to have seizures, not very aggressively treated because, quote, kids with autism have seizures. When those seizures continued to increase and get worse and worse, I was questioned, maybe that's just a behavior. You know, he also has some dystonia, so he has some unusual movements. It was difficult sometimes to tease out what was a seizure and what was an autism spectrum symptom. He is nonverbal. His peers, our friends who had children on the autism spectrum, made progress. Developmentally, they made progress. In school, they made progress. Ben didn't make progress and, in fact, regressed more. Over time, the seizures became worse, and eventually he was given an LGS diagnosis. But I think it's important to look at the fact that the behavioral, the developmental, the cognitive, the communication, those symptoms are as much impactful as the seizures are.
Absolutely.
When our kids can't talk, JJ doesn't feel pain, and so we don't know that he's injured. You know, so many of our kids are not able to communicate except in the very subtle ways that
Helen spoke to.
that she described. Those are as much an impact and as important, and I would just ask the professionals in the room, when you hear the word autism, please don't turn off your brains. I know as parents of kids on the autism spectrum, we can be a real pain in the butt because we don't have enough information. But please be on the lookout. There are many, many children with LGS who also have autism. There are many children with autism who will go on to develop very severe seizure syndromes. I just really wanted to be able to say that. Thank you.
Great. No, thank you. You brought up what I was going to bring up next, is the topic of developmental delays.
We have a question here.
Sure.
She's been waiting
Okay.
for us, so I want to make sure.
I just wanted to quickly answer your question about how you noticed when seizures changed. I noticed that every developmental milestone, or every time that my son grew in exponential form, he would change seizures, and none of the neurologists would identify that with me. I'd say, oh, his seizures have changed. Well, why? I think that's because he's developing. You know, he's growing older, and they're just changing. And now he's in this wonderful thing where the docs say, oh, he's not having a seizure, it's a behavior. And so the schools think that it's a seizure, so he's being sent to the ER constantly because they say it's a seizure. But we're like, no, it's called a behavior, and he's not tonic-clonicking. He's just expressing to you that he's having some issues. And other people don't see that. They just see, a movement, and they say, oh, seizure,
Yeah.
So that's my answer to your question.
So not as much keen observers as you are to know that subtle difference. And I think that evolution over time with puberty, and I mean, there's a lot going on in the physiology.
Can I just respond to what you were talking about with autism? I went to my son's neurologist so many times and asked, is this autism? And she'd say, no, he has autistic-like behaviors, but it's not autism. So now, of course, I'm confused because I'm wondering, is autism an actual diagnosis, or is it just a symptom of something else? So yes, a lot of our kids they either have autism as a secondary diagnosis, or it's just autistic-like stuff going on. So yeah, but as long as she said, I'll call it autism if it means you'll get more stuff.
Right.
And I said, okay, fine, that's great.
Access to services and supports and all kinds of things that have been built around those labels. Tracy, did you have some stuff from the web?
I just wanted to ask, going back, I agree with everything that's said, but just one thing that you didn't, when you talked about head injuries and skull fractures, one thing that didn't come up that I really want to come up is aspiration pneumonia. How often? I mean, when Savannah had pneumonia, which she would aspirate during a seizure, probably 15, 16 times before she was 10 years old.
Wow.
So, I mean, I just would love a show of hands on that one. Aspiration pneumonia ever in your kid?
No matter how many hands, that's too many, right? Developmental delays. We've talked about some of those. Great to bring that up. It's such an important feature, again, kind of central to the diagnosis and the syndrome itself. How does that impact your daily life as caregivers? Heard a lot of testimony already about the inability for kids to live independently, for do a lot of the activities of daily living on their own, even within the home.
Hi, everybody. My name is Laura Kelly. I am from Cherry Hill, New Jersey. This is my lovely daughter, Alexa, who is 31 years old. I actually feel kind of lucky because Alexa was born with Down syndrome, so I knew within an hour my road of raising her was going to be very different. So she's 31 years old. To the clinicians in the room, I will say that a lot of this stuff, same story. Things got ignored. She's having seizures. No, she's not. Hypervigilant mother, whatever. But what I ask of you is, when you don't know an answer to something, just tell us. You just don't know. And you don't know where this is going to go. I understand you want to give most of us hope because these are devastating disorders that our kids go through, and we have to learn how to live with it. And we can't make good, informed decisions unless we have facts. And if you don't know the answer, give us a resource. Send us to someone who does. Hook us up with another parent or something. Now that we're in the adult world, and those education entitlements fall away, our kids are in the 1% group. Unfortunately, this is not the 1% we'd like to be in, but we're in it. And services for them are incredibly difficult to get because of their complex needs. As states look to close down developmental centers to capture the federal dollars that they can get when their kids are living in the community, we have all these providers who want our kids because they often have very high budgets because of the complex needs, but they're not able to care for them in these group home situations. My daughter has lived in an institutional setting. She's lived in a group home that was, I can't even go where it was. It was terrible. They put her into the ICU twice within the first 6 months of her placement and then evicted her. And now she's living in her own apartment with a budget, a housing voucher, staffing that I manage and train. It's very complicated managing all her funding streams. So I tell families to get involved in your state council of developmental disabilities because many of those people who do those advocacies, their kids are not in this 1%. These are kids that may go out and hold down jobs, can go to day training. Our kids can't really do that because there's no medical oversight in a lot of these places. There's no clinical oversight managing their day-to-day drugs. The only requirement to work in a group home is a high school diploma. And that too, it's the only licensed setting where someone with a high school diploma can give out medications. This can't happen in schools, it can't happen in prisons, it doesn't happen in the hospital. But in a group home, substandard care is allowed for this population. I don't know why, no one's ever able to give me the answer for that, but it's another thing that we have to address. And we have to join forces. So I encourage you to join your state councils, to go to the meetings, and to have your voice heard, because we're not going to be here forever to take care of these children, and what's going to happen to them is it's not a good picture right now, and we all need to really work at that.
I think you raised, Laura, a really important point, and it's one, Jen, that you mentioned during your statement, that as your kids are getting older, you're getting older too, and what is their quality of life as your caregiving abilities may decline due to your own age, and how do we prepare for that? I think those are important impacts.
A lot of kids end up being dual diagnosis with IDD and a mental health issue. And my daughter, too, has had really significant behavior issues. And honestly, they're worse than the seizures. I'll take a seizure any day over behavior because those are, you can't even live your life when right, you're going to get hurt, they hurt themselves, you can't go out in public, you do go out in public, people look at you like you can't control this kid. It's like, clearly I can't. If you can do a better job, you can have her. You know, never get any takers though. And I mean, it sounds terrible, but you know, I've been at this for 31 years now, and yes, it's totally broken my family. She has 2 other siblings that are very conflicted in their feelings about her. They want to love her, but there's also, I know, deep resentment. My husband and I spend no time alone together in the situation that she's currently in, and you know, anytime she doesn't have staffing, somebody from the family has to fill in that hole, and they get resentful of me asking. The other thing, too, I would mention is Alexa has a pulse oximeter. One thing that has improved my life greatly because of sleep. She gets hooked up to every night. It was incredibly difficult to get. She got it because she's had sepsis 3 times from aspiration pneumonia. You know, she's been on ventilators and has had upwards of 3-month-long hospitalizations. So she's had such respiratory issues, and now, of course, she has lung problems because of it all. She has a pulse oximeter. And yes, it's a pain in the neck because it comes off during the night, but I do know that if suited occurs, I'm going to have a heads up with it. And so I encourage, you know, help us get the equipment we need. Figure out some way to do it because it's really hard. We have to fight for everything. I wish the insurance companies were in here to listen to what it's like to renew Epidiolex every month, and God forbid you have a change in dosing. You know, you just really, by the time you get off the phone, you just want to kill yourself. Because dying would be easier.
Yeah, thank you, Laura. I want to invite the second panel to come up to the front. I'm going to quickly change these. And this conversation could go on, and it will go on. It's almost impossible to disentangle the symptoms and the impacts from the treatments. So we will have a chance to revisit some of these topics again, but the behaviors are something that has already been mentioned, and those can be both connected to the treatments, the side effects, but I think may also be a part of the syndrome. Just come on up and take your seats. Yes?
Okay. The mention of pain, especially in your nonverbal kids. My son had a non-displaced fracture in his calcaneus 3.
Can you stand and maybe face that way just so?
I was asked to bring up the mention of pain, especially in your nonverbal kids, because it's really hard to pick that up. My son had 3 non-displaced fractures in his calcaneus. The only way I knew was he stopped walking.
It took me a long time to convince the orthopedic that he needed an MRI of that foot. They kept doing x-rays, and I'm like, I'm enough of a nurse to know you need an MRI. You need to sedate my kid. They found the fracture. He went through, I'm very embarrassed to say, 3 casts because he broke them.
Wow.
And then they finally just washed their hands of it. But the bigger issue is I have no way to tell if my son is in pain. His pain threshold is so high that I can't tell. So for all of you guys out there that are looking for something to look into, that would be great.
Thank you for that. That's a really important aspect. And our 5th panelist has taken his son to the men's room. So we're going to just talk about the behaviors for a minute, because last night there was a heated, friendly heated discussion about seizures versus behaviors and which ones you would prefer could go away faster. I think everybody wants all of it to go away. But that tension between which of these is the greater impact kind of across your child's whole life. Would anybody like to add their perspective? Brittany, yeah. Right behind you, Kathy.
I would say the behaviors, because the type of behaviors we see are not just, I think when people hear behaviors, I was a teacher for 16 years, you're thinking of a kid misbehaving in class. That's not what we are talking about. Like I was ready to call an exorcist kind of behavior, so these are, for what we've seen, it's like a psychotic break. It's not triggered. It's not, well, you can, calm them down. Somebody said, well, take them to a psychologist. We're not talking about that. These behaviors are unprovoked, and they can go on for days, and they are so aggressive and just lashing out that to me, it's like a seizure. And we tried the ABA. I tried a spanking. I mean, you know, like I'm trying this stuff and he's looking at me like, no, it's not happening. But the random and weird thing about it is when he gets out of that cycle, it's like it didn't happen.
Just
He's
back
trying
to
to hug
normal.
me and I'm like, dude, I'm still mad about yesterday, you know? So I just think it's important when we say behaviors, we are not talking about a typical just irritant. This thing is real. It is as bad as a seizure.
Thank you. Thank you for that. We're going to take one last comment, and then we're going to shift gears and talk about treatments.
My name is Eileen Miller, and I'm here from Hope for Hypothalamic Hamartoma, and a percentage of our patients, like so many of these other syndromes, also have LGS. And I just want to second the comment that was just made. For many of our patients, it's the behavior that is the graver of the two concerns. And I think that speaking on behalf of the Rare Epilepsy Network and many of the other organizations in this room, I think we've realized in the past few years through the efforts of LGS and TS and other organizations, Child Neurology Foundation, that this is a common concern across all of our rare epilepsies. And so we don't want to have to make the choice between curing the seizures and curing the behaviors. We need help with both of those. And I think moreover, and equally as important is that we need the medical professionals, the drug developers, the FDA, and all the other folks involved to appreciate that when you see these specialists, you're seeing them in silos, and it's not enough for our families to get one recommendation from the neurologist and then be dealing with the psychiatrist and the psychologist and getting a whole second set of recommendations. We need these silos to be cross-communicating because these drugs also have interactions for our patients as well. So it's critically important that the silos, we sort of break down those barriers and those discussions and make sure that that sort of cross discussion is taking place as well.
Great, thank you. As I said, we are not leaving this topic of symptoms and impacts on daily living. It is intrinsically part of the treatment conversation as well. But in the interest of time, we're going to move on to kind of the second part of this dialogue and hear from another group of your fellow experts about their experiences in the treatment approaches that they have explored in the interest of both controlling symptoms, but also enhancing quality of life. And Dr. Knupp showed us that cycle that she said most of the families are caught in. It otherwise looked like a very straightforward algorithm, except for this vicious sort of cycle in the middle where many of you are caught. And these 5 brave individuals are going to bring those challenges to life. So with that, Dale, I'll invite you to start us off with the story of Adam.
Thank you so much. I would suggest that maybe the next FDA research study might be to study the superhuman traits of LGS moms and the women that I'm here on this panel with. But my name is Dale Todd, and I'm from Cedar Rapids, Iowa. And my story is that my wife and I, Sarah, who's back in the back, we worry in shifts. She has the first shift from 10:30 p.m. till about 12:30 a.m. Before she sleeps, she juggles this complex world of IEPs and transition planning and day-hab and doctor's appointments in her head. She navigates the coordination of my son's medical needs like an air traffic controller. But sometimes in the morning, I find a balled-up Kleenex in my bed, and it tells me that she's quietly cried herself to sleep, fearful for my son's future in a world with limited resources and programs for adults with special needs. I find myself on the second shift from about 4:30 a.m. until I get his meds at 6:45. And at that time, our house is pretty silent at 4:30 in the morning, and I lay in bed listening to the changes in the rhythm of his breathing with a high-tech baby monitor. I listen for the timing. Its video monitor catches his subtle movements, invariably mistaking his stretching for a seizure. So now it's 5 a.m. and I'm too awake to go back to sleep. So it's now my time to wonder about his future, hoping that today will be a seizure-free day, but making changes to my day if my gut tells me that it will not be. This, my friends, is just another day in the life of an LGS family. My son Adam is the joy of our lives. He was born small but grew into a healthy little boy with a cheerful disposition. But at the age of 3.5, he had his first seizure that at least we were aware of, and he was soon diagnosed then with epilepsy. Like many LGS parents, we have experience with a multitude of treatment options. Today, my son is 20. We're lucky that we had more than just phenobarbital and Dilantin to choose from in the beginning. We also feel fortunate that Adam's medical team consists of a primary care physician and a pediatric epileptologist at the University of Iowa. Unfortunately, most epilepsy patients in Iowa are treated by a primary care physician who lacks specialized training needed to make a correct diagnosis and appropriate treatment option to combat seizures. To date, Adam has tried and used more than 14 different medications. We graduated from one seizure med to monotherapy, now to 5 different medications that are used on a daily basis. When LGS families get together, it's not just what medication are you on, is your son on or child on, but how many different medications are they on? There's been no silver bullet, but in combination, different medications have worked together to help us gain a quality of life for Adam that many LGS families have yet to achieve. We have participated in clinical drug trials and will continue to advocate for their use. It was a clinical drug trial for clobazam that proved to be a lifesaver for reducing his nasty drop seizures. When a seizure activity flares up, we use rescue medications. These rescue meds have varied over time. In the beginning, it was Ativan and Diastat, a rectal gel. Now, more recently, we use a nasal spray that helps to mitigate seizure activity more quickly and effectively. Adam's rescue meds go wherever he goes, and all his caregivers are trained in how to administer them. We've used these medications carefully, knowing that too much results in an extended period of lethargy, lack of appetite, and interferes with his ability to swallow food, including his seizure meds. Today we deal with the constant side effects of his medication. This includes constipation, drooling, poor appetite, and challenges with balance, drowsiness, and poor sleep. In terms of non-medication related treatment, surgery has never been an option for us. His seizures are generalized, and he lacks a focal point in his brain. He had some benefit in terms of a slight decrease in seizure activity while on the ketogenic diet, which we tried early on. They said it was complicated at first, but we found it no more complicated than his medical regimen. For the 2 years that it worked, he was able to decrease the level of meds, but a flare-up of seizure activity required us to go off the diet. The most important medical device we rely on right now is this seizure monitor that I referenced earlier. Adam meets all the characteristics of sudden unexplained death in epilepsy or SUDEP, as Kathy described in the first panel discussion. So we are vigilant, and while we do not discuss it, the possibility that we could lose Adam weighs on us in ways that parents of healthy children will never understand. Keeping Adam healthy is one of the most important goals in his overall health care plan. It's a constant challenge and involves consistency in care, much of which falls to my wife, who challenges the entire team through a combination of physical and occupational strategies supplemented with proper nutrition and diet additives. Under the best circumstances, Adam is able to participate on his high school cross-country team. We know in this aspect we are outside the norm of LGS families. We are the lucky ones. But with the slightest change in sleep patterns or an oncoming cold or virus, we soon can find ourselves fighting for his life. Missing a dose or coming down with the flu reminds us instantaneously of the fragile nature and inherent danger of LGS. Adam has been hospitalized several times for almost 2 weeks at a time based on the delicate nature of the co-occurring disorders that are manifested in his LGS. A case of the flu last year resulted in a near-death experience for him last year, where we were a mere 15 minutes away from losing Adam if invasive procedures had not been taken in the emergency room. The lesson here is that these kids are incredibly complicated, and what works for one might not work for another. It also means that seizure and rescue protocols need to be developed and refined for each child on an individual basis. For instance, slight differences in the absorption rates of medications can have long-term negative implications on their seizure control. These are all lessons that parents have had to learn on their own. And while LGS has impacted and changed our way of life, we made the decision that we will not let LGS control our lives. Depression and feelings of being overwhelmed are all part of the day-to-day struggle of parents and caregivers of people with LGS. But if there's one silver lining that should be instilled in us all, it is the power and strength that comes from efforts that collectively bring together caregivers, medical professionals, and members of the research community with regulators like the FDA. For too long, rare diseases like LGS have not had the emphasis or resources that other diseases have enjoyed. So we hope that today marks a turning point in our quest for new answers in our journey. We look to the FDA to help provide leadership and resources as we all work towards improving the quality of life for those we love and for those with LGS.
Good morning. My name is Andy Cooper, and I am the parent of Cannon Cooper. I'm from Oklahoma. Shortly after Cannon was born, I opened a savings account to take him to the Grand Canyon. My parents took me to Disney World when I was 7, and I remember very vividly what that trip was like and how hot it was, outfits I wore, dancing with Mickey, and I knew so when Cannon was 7, he would remember the Grand Canyon for a lifetime. He was a very precocious toddler, full of spirit and joy, and he was typically developing. We had dreams of him playing under the Friday night lights, winning spelling bees, chasing girls, and building forts. Cannon had his first seizure when he was 3.5 years old. He was diagnosed with childhood epilepsy, and we were told not to worry, that he would grow out of it and be totally fine. We started our first anti-epileptic drug, ethosuximide. And within days, I started to see a different child. He started to act like a zombie. He quit walking. He quit talking. He didn't seem to have a care in the world. He had no affect at all. Seizures began to soar after that. When we weaned him off ethosuximide, we started Depakote, and Depakote made him crazy. He was angry when I was happy, if the sky was blue, if he cuddled, or if I gave him his space, and there was nothing I could do to help him. And on April 15th of 2012, we attended my niece's baptism, and he had his first tonic-clonic seizure and vomited everywhere shortly after, ruining the party. And that wasn't even the hard part. Later, he had 19 more seizures that afternoon, and all of my hope was robbed from me that day because I knew something else was going on. We started seeing a new neurologist, much further from home, but for the first time I really felt heard. We were again weaning off meds for a new plan of care. This time we tried clonazepam, and Cannon was noticeably losing skills and having hundreds of seizures a week. We were no longer used to a normal or what we could expect next. And finding your child face down in his dog's water bowl is never what I expected out of parenthood. The unpredictability of never feeling safe to turn your back, to cook a meal, to shower, or even change clothes is the most heartbreaking, lonely feeling in this world. We were sent to the Mayo Clinic and received a diagnosis of Lennox-Gastaut syndrome. And with the new diagnosis came yet another new plan of care. I'll never forget watching as the epileptologist she drew a map of options if her first plan were to fail. And for an incredibly smart woman, I remember thinking how awfully uncertain she seemed in this plan. She gave me side effects of losing visions and loss of bone marrow production, which ultimately caused death in my 4-year-old. How does a parent ever have to choose between those two side effects? Why should I ever have to choose? During our 17-hour drive home that weekend, I could only think about the terrible options for my son. And my vision for watching Cannon play under those Friday nights, they became broken dreams, and still are. My dream now consists for Cannon that one day he'll cross the street safely, write his name, or simply tell me about his day. Those things, and of course, seizure control. Onfi was an immediate add-on for a drug for our new diagnosis of LGS, and it decreased his drop seizures and got Cannon out of wearing a helmet for safety. He was taken off clonazepam, and we started Pferd. And in turn, we had to do monthly draws for lab work to watch for aplastic anemia, an adverse side effect that can arise from the Pferd. Once we started, again, Cannon's behavior changed, it soared, and at 6 years old, he busted my windshield out of my car. There was no antecedent to this behavior. And if I had it to do all over again, I would choose seizures every single day, because at least I know how to manage those. Still having hundreds of seizures a week, we were scheduled for a tonsillectomy in preparation for our next treatment option, the vagal nerve stimulator. We paused our plan when we learned from the LGS Foundation that there was a clinical trial happening in California. You had to be 7 years old, you had to have had no devices, surgeries, and failed multiple drugs, and we had met that criteria. To participate in this trial, we'd need to fly from Oklahoma to California every 6 weeks. So finally, on Cannon's 7th birthday, we did board that plane, but we did not get to go to the Grand Canyon. Instead, we went for a gift we'd later know as the trigeminal nerve stimulator. It was a non-pharma, non-invasive approach that actually worked with no side effects. The device decreased his overall seizure activity by 82%. His cognition, speech, language, and his memories all increased. Shortly after our 4th visit, we received a call that the trial was canceled with no explanation after several asks. I gave up. Again, my hope was gone. Seizures came back quickly, and he had lost everything he gained again. Cannon is now 11 years old, and he's 5'4" and 130 pounds. He's built like a Division I athlete, and he functions like an 18-month-old. My message to our community, my family, and Cannon's school has always been, when we know better, we have to do better. You hear our stories today, but they're not just stories. They are very precious, precious lives and testimonies of lives lost. This is not just about Cannon, it's about the children whose parents are not before you today. We need these kids not only to live, not only to survive, but we need them to thrive. Our children need better because we know better, and you know better. They deserve a great quality of life and seizure control. Please don't make us continue to choose.
Good morning. My name is Elizabeth Terry, and I'm from St. Louis, Missouri. And my daughter Spencer is 14 years old, and I'd like to talk with you about AEDs. Spencer is currently prescribed 4 AEDs, and 2 of them are benzodiazepines. And in her short life, filled with an ever-changing cocktail of AEDs, only one has provided limited success, and that came at a cost. Lamotrigine didn't help her seizures, but it did clear the storm clouds in her brain. And so now she can do simple puzzles, and she can gingerly pedal an adaptive bike. And I'm so proud of her. Yet night after night, she takes 3 heavy sleep aids in combination with the benzos to sleep, to combat the manic insomnia that comes with the lamotrigine. In fact, I feel that my kid has endured every unpleasant side effect in the book, including those that rob her dignity, like tremors and drooling. Because of that cocktail of AEDs in her body, I've become terrified to give her any ancillary medications because I don't know how they're going to react with her seizure meds. And 2 such incidents come to mind, like the time she was given medicine for a yeast infection and she seized nonstop for 2 straight days. Or the time that she was given an ADHD medicine and that put her in near fatal non-convulsive status epilepticus. Positivity is a rare emotion when it comes to AEDs, but I was actually excited to try Epidiolex once it was on the market, having been denied the access to clinical trials by Spencer's conservative Missouri neurologist. Even though experience had taught me this was just another seizure med, I allowed myself to be swept up in the fervor generated by the media about anything to do with marijuana. I foolishly hoped it would be our miracle and she would have no more seizures with no serious side effects. The letdown was phenomenal, even beyond comparable to most AED failures. My daughter suffered Stevens-Johnson syndrome upon the outset. This potentially deadly rash caused by drug interactions hit Spencer particularly hard. I sat with her in the hospital and marveled at how every inch of her skin was covered in red rash, and I watched the skin peel off her lips in sheets. And the devastating side effects didn't stop there. My already thin child stopped eating and stopped drinking, and she lost 10% of her body weight. My little girl lost hair, and she succumbed to extreme lethargy, practically sleeping for 6 straight months while we titrated toward the optimum dose. There's a seizure. We're all with you. After spinning our wheels on the AED merry-go-round, I again found myself hopeful with the discovery of an innovative, optimistic epileptologist in Ohio. So for the past 2 years, I've driven 16 hours round trip with my daughter every 2 months to see this new doctor. Yet working with a doctor more willing to consider a full range of options, including more aggressive treatments, that came with heart-wrenching decisions for me. Surgical decisions, and I still struggle to forgive myself for putting my child through a corpus callosotomy, which did not give her any seizure control. In fact, her seizures are worse. She continues to endure physical therapy rehabilitation even now, over a year later. And so the AED merry-go-round continues, augmented with an entire subset of meds. My daughter takes Miralax daily because seizure meds are notorious for stopping kids up. She takes birth control pills in an attempt to stifle my diaper-wearing 14-year-old's menstrual cycle. And because the hard truth is that my daughter is statistically likely to become a victim of sexual assault as a vulnerable female. My daughter takes Citracal because years of seizure meds, especially Depakote, make bone density loss a near certainty. There is more work to be done. I appeal to you to continue your focused research. My biggest dream for my girl is to take away the seizures which steal so much of her life. Taking away the seizures would take away not only the horrible medicinal side effects, but also the lengthy recovery time the exhaustion, and the mysterious pain which makes her hit her head every day and cry out. My tears fall with hers. Thank you.
I want to begin by thanking those families who were able to bring their warriors with them to the meeting today. And I love that we're hearing their voices added to the conversation. So see them, notice them, love them, and help them get better. So I'm Karen Groff, and I'm from Columbus, Ohio. We believe that Lennox-Gastaut syndrome is a relentless thief that has stolen our child, our money, our time, our family, our friends, and indeed our very lives. And although we are constantly overwhelmed and terrified, we are strong and we must persist. We dedicate ourselves to the fight for a reasonable quality of life and treatments that will stop seizures without causing new difficulties. Our son Dan is 33 years old. He's lived well past his original predicted life expectancy of 10 years, yet his development has regressed to that of an 18-month-old. He's our very, very tall toddler. That's occurred over 30 years of treatments and trials that often hurt more than they helped. Treatments that have failed to save our boy. Treatments that drug his already fragile brain, change his personality, and cause intolerable side effects. Treatments that don't stop the seizures. Yeah. Treatments that include 27 different AED medications alone and in combinations, a very restrictive and unappetizing diet, 6 medications addressing behavior, quote unquote, or intermittent explosive disorder, anxiety and depression, 7 medications to regulate sleep, 8 types of insulin, and another 7 treatments to address allergies and complications from type 1 diabetes. But there's more. Rescue meds for seizures that won't stop and blood glucose levels that go too low. Gamma globulin infusions, 5 surgeries to place and replace the vagus nerve stimulator, and brain surgery, a complete removal of his corpus callosum to disrupt seizures that spread through his brain like lightning, causing serious falls, laceration, broken bones, and broken teeth. Countless trips to the emergency room and hospitalizations that often leave us exhausted and not one bit better off than before. In treating Lennox-Gastaut syndrome, we have decided to take an aggressive approach. We believed that if we could stop the seizures, learning could continue, risk of sudden unexplained death in epilepsy or SUDEP would be reduced, and quality of life would be improved for all of us. But what good is a drug that reduces my child's seizures by half when he's already having hundreds each day? What good is a treatment that changes his personality and causes behaviors that lead to injuries and inability to sleep? We often wonder what is worse, the seizures or the available treatment. Clinical trials seem worth the risk because we exhausted approved treatments. We travel to other cities seeing doctors on the cutting edge, and our son continues to have thousands of seizures and decline every year. The diagnosis of type 1 diabetes at age 12 meant Dan was no longer eligible for most clinical trials. And while we understand this metabolic disorder means that the waters of research are muddied, we don't know what to do now. We realize we are losing ground against LGS, and even the constant occupational, physical, communication, and play therapies are inadequate weapons against the regression claimed by this formidable thief. We dream of treatments that eliminate the big seizures, treatments that do not contribute to already present behavior difficulties or interfere with learning, and treatments that allow our son to be clear-minded talkative, and fully able to express his sweet personality. We must have rescue medications that are easy to administer and actually stop the nonstop seizures, keep us out of the emergency room in the hospital. We need to be able to identify the underlying cause of his LGS and have early treatments that work. We must know what combination of therapies is best under which circumstances, and we must stop the progression of LGS. Thank you.
Where'd she go? Can you send it, can you take it back to the last slide, Ivy? There we go, thanks. So I am Tracy Dixon Salazar from San Diego, mom to Savannah, who has been diagnosed with 3 different DEEs, including LGS. According to my records, I've witnessed Savannah have more than 40,000 seizures. At first, all I could do was count them, so I did, and 24 years later, I still do. I vividly remember Savannah's first seizure when she was just 2. She had met all of her milestones. She was healthy. But we were awoken to the sound in the middle of the night of her hacking and gagging and choking. It was coming from her room, and when we ran in there, we saw her in the throes of what was a tonic-clonic seizure, but we had no idea that was what it was. We thought she was choking. In the beginning, the doctors called them episodes and spells, not seizures. We only learned they were seizures by reading her medical chart. It turns out that the doctors didn't want to label her with something that would follow her around and cause stigma. We were assured that medication would control these episodes and that she would likely outgrow them and that she could go on and live a normal life. Savannah's seizures got worse despite treatment. The first drug she tried, Tegretol, gave her a life-threatening rash. The second, Depakote, made her self-injurious and psychotic. Both drugs made her seizures exponentially increase in number and brought on other types of seizures. At this point, Savannah was having multiple types of seizures, hundreds a day, and had to wear a protective helmet to protect her from seizure-induced falls. She's had skull fractures, broken bones and teeth, a severed nose bridge, busted eyes, you name it. This was despite the introduction of phenytoin and clonazepam together. They called it intractable epilepsy, and developmental delay was becoming apparent. By the age of 4, she began to have clusters of seizures that would last for hours, requiring ER visits before at-home rescue meds existed. At age 5, the pattern continued, developmental delays became even more apparent, and Savannah was finally diagnosed with LGS. Our days back then were spent just trying to keep her safe. The number of seizures that she had every day were completely unpredictable. One day she would have 5 to 10, and that was a good day. And then the next day she'd have hundreds. I stopped counting after several hundred and would just put a greater than sign. And the day after that was anybody's guess what you were going to get. And then the first thing that I did every morning before getting out of bed, like so many parents here, was put my hand on Savannah's chest to see if she was still breathing. I still do this. With frequent tonic-clonic seizures occurring during sleep, we live in fear of sudden death. This was our lives for 16 years. We continued to try treatment after treatment because what else do you do? We tried and failed 26 in total, none of them making a dent in her daily seizures, none of them making a dent in her weekly episodes of status epilepticus and clusters, none of them making a dent in her frequent injuries and hospitalizations. The seizures were winning. As a genomic scientist, I scoured the literature for clues that might cause or what might control Savannah's seizures. I spent 12 years getting a PhD because I felt so helpless that I couldn't help my daughter. Around the time that she turned 18, I somehow miraculously in my research, and I still don't know how, connected documented mutations in numerous calcium channel genes in Savannah's body as a potential driver for her epilepsy. After undertaking painstaking risk-benefit assessment of the available data with her doctors, she began a course of an FDA-approved calcium-blocking drug that's not used for epilepsy, verapamil. It's used for high blood pressure and for arrhythmia. At that time, before treatment, Savannah was seizing every day, having about 75 seizures a week. She was going into clusters and status 2 to 4 times a week, and that number was increasing every year. And she always required emergency interventions, first with rectal rescue meds, then with a trip to the ER for intravenous meds, and then into medically induced coma if that didn't work. Within 2 weeks of starting verapamil, Savannah had an amazing response. She had a 95% reduction in all of her seizures, and her clusters and episodes of status epilepticus completely stopped. After 16 years of daily, unrelenting, hellish seizures, Savannah's life was changed. Our lives were changed, and we didn't know what to do with ourselves. That was 8 years ago, and Savannah continues to maintain those numbers. Before this new therapy, Savannah had the mental capacity of a 3 to 4-year-old. Now they estimate she's at a level of a 4 to 7-year-old. Keep in mind that she's a young woman, 26 now. She can talk in short sentences. She can walk with help. She shows her sassy and funny side of her personality. She has many more good days than bad days. She's truly one of the lucky ones, and so are we. Sadly, those 16 years of unrelenting seizures had done so much lasting damage. She's very unable to do little independently. She can't eat independently, bathe, toilet, take her meds, and she still has 2 to 3 tonic-clonic or tonic nocturnal seizures every week. But she's one of the lucky ones. She's been weaned down from her previous 7-drug regimen to 4 and come off of her neurostimulator. I'd like to find a treatment that would further reduce her seizures, but we don't know what might make things better without risking making her worse. I'd like to get her off of Dilantin, which she's been on since she was 3, which we only recently learned from adult neurology specialists causes cerebellar atrophy, which is progressive. The pediatric neurologist never mentioned this. But that change carries risk as well. We live in terror of going back to that hell of daily seizures. And we don't know whether to leave her on a medicine that we know is harming her and risk going back to that. Even with the relative success of the current regimen, I can't help but wonder, what if? What if we had found verapamil sooner? Could we have prevented some or all of the damage that was done? This is just one of the many, many questions that we still can't answer. Early treatment with a precision medicine may have helped her. There is still so much work to be done. I'm personally so grateful that the treatments exist for LGS and for DEEs. Because if they didn't, that means that we're just giving up on the kids that have LGS and DE today, and we're not even trying. It would feel like everybody had just given up on our children. But we need better treatments. We need more rational interventions instead of the dartboard approach to seizures. Let's try this one next. And we need a better understanding of which treatments might help which patients and when, and which ones are going to do harm. But not just for our children, but for the next generation of Savannahs and Dans and Spencers and Caddens and Adams and all of the families living with DEEs and with LGS. Thank you.
Again, thank you to all of you for the work you put into crafting your statements and delivering them with such courage and so compellingly to make us all think about the journeys you've been on and that your kids have been on. Join me again in thanking this panel. Okay, we have a lot of ground to cover in the next 40 minutes to really do justice to the way that all of you apply your expertise to determining what kind of treatment approaches you're going to take on behalf of your kids with your doctors by your side. I'm going to ask you to do something a little bit out of the box. We did something at the beginning of the meeting a little out of the box. If all of the the family caregivers would stand for a moment, just in your spots. Okay. So thinking about the loved one that has LGS, DEEs, if your treatment approach has included 10 or fewer medications, take your seat again. How about somewhere between 11 and 20 medications? How about between 21 and 30 medications? So somewhere in that 21 to 30, anybody higher than 30, I think everybody took a seat at that point, but that is a tremendous amount of pharmacology, and we didn't even throw medical devices and surgeries and other types of approaches into there. And as Dr. Knupp's kind of diagram showed in the morning, it is, as Tracy called it, kind of a dartboard approach to what do we do next. A lot of experimentation, way outside the bounds of where anybody can look to the evidence for the, very much trial and error, hope and prayer that you're employing. So we can kind of break up the seizure medication approach, I think, into two buckets that sometimes overlap, but there are the mainstay therapies, and we heard about a number of those, in addition to the kind of the rescue medicines that you need to use when you need to stop a seizure from creating more damage. Anybody want to share their brief experience? And because we have so little time, I'm going to just ask you to really just sort of make a quick statement, and let's move around and get to as many people as we can.
Real quick, as far as treatment, Jeremiah responds very well to clonazepam when it's cluster seizures. However, if I'm going to give the clonazepam, which is really no choice because I don't have a choice, I have to protect his siblings. So what that means is he will physically harm them. I think there was a parent in the back, I think she's wearing yellow, that stated that it is like a psychotic break. A doctor, sort of brushed me off and said, well, he's 6. Well, yeah, that's great. At some point, he's not going to be 40 pounds. And even at 40 pounds, he can still kick my butt, let me just tell you. It takes quite a few of us to restrain him when he's in that mood, and it is 3 to 4 days after rescue medication is given to stop the seizures that I have to give my other siblings to a family, or like Christina said, to a neighbor, anyone that are willing to help me out so that he doesn't harm them, because he has done that.
Another perspective on how you're dealing with seizure control.
And I'll just add to the behaviors. It's difficult to say, but there are literally protocols for my brother to get takedowns. So basically just wrap him and take him down, because otherwise he's going to hurt other people. And we'd rather have, I think, I can speak for my parents, we'd rather have seizures than that.
We've had to lock ourselves in another room sometimes when his behaviors are that bad, and then just let him destroy the house and worry about that when that's over with.
Wow.
But at least there's no physical harm to anybody.
Oh, just to get descriptive here, because, hey, we're here. I I know you guys don't want me to talk about this, but Michael literally took out a hammer and tried to chase my 2-year-old. He was two at the time. He was my 1-year-old nephew, and it is probably the most traumatic thing that my parents, yeah, they had to call the police on my brother.
Wow.
These are real things we don't want to talk about, but we have to.
And when I called the police, I made it a point. This was his first psychotic episode. As I'm telling, they're asking me questions, and I said he's an 18-year-old male. And then I quickly realized what the police would interpret that as. And then I had said he is developmentally disabled. He weighs 80 pounds, and he is at the level of about a 4-year-old. And I think that helped the police come in a very different way than they would have otherwise.
Yeah. Thank you.
In our case, my son had the best seizure control with CBD and Epidiolex. He had an increase in seizures with Depakote. It just kept getting worse and worse. And then we added Vimpat, and we added Onfi, and nothing has really worked except for the ketogenic diets helped him a bit, but really the CBD and Epidiolex has been really amazing for him. One thing I just wanted to say about the Epidiolex is we didn't want to give it to him for a long time. We were doing Charlotte's Web. I was really disappointed to find out that they decided to put sucralose in it. You know, like our kids already have enough toxic stuff being pumped into them. There's other options, like with Charlotte's Web, they have essence of mint or something that they flavor it with. Like, why are we putting toxic things into things, like making things worse instead of, you know, better for the kids?
That's a good point. Thank you. Go here and then to the back.
Something that's helped Jordan has been when we switched to the extended release medications, because I think they keep him even over a longer period of time. So we do the extended release Lamictal. And then also we tried the Epidiolex, which was awesome because it was covered by insurance, but he actually had an increase. But we do the CBD oil over the counter. I don't know if it's the THC, I don't know what it is, but that has had a benefit. And then I don't know if anyone has talked about sleep, but sleep is so, so important. We have blackout shades, and we have a padded room. We have like all kinds of things to help him to be able to stay asleep. A sleep-safe bed and weighted blankets, like eucalyptus and whatever.
Sounds like a spa.
But if he can get a good night's sleep without seizures or without that stuff, it makes such a huge impact. And I just want to say this one last thing, because I'm not talking anymore today, which we've seen like cycles. So I haven't heard anyone really talk about that, but it's like he has a seizure cycle, he has a behavior cycle, he has a everything's perfect cycle, and then it just go, and he has a bizarre behavior cycle. But we see it go around, and there has to be something in the brain that causes him to go through those cycles.
Thank you for all of that. And I'm so glad you brought up sleep. We didn't touch on that as much, but it has come up time and again in kind of ways that we know it's important. So thank you for drawing attention to it.
I think too, we all go through these, you know, we just try, and then occasionally I think we all have those game changer meds that we can all, that's almost like you know, I can mark my son's progression through, you know, by Felbamate, Onfi, Epidiolex, and then there were all of those other swirl of meds in between. But those were the ones that were, you know, that kind of took us to the next level.
Got you to the next piece. I know we saw one back there, and then there's one over here to the side.
Hi, I'm Leah. I'm with the SCN2A group, and one common word I've heard from almost every mom in here is the word lucky. Like, have you ever heard a group of people say how lucky we are, except for us? We all find, I guess it's all about perspective, but we did not have a very good journey with getting control of seizures until researchers looked at my son's very specific genetic variant and suggested a medication. So because of that, we have complete seizure control. So it's a case of precision medicine, kind of like what Tracy was explaining with her daughter. So, I mean, I think that's just the direction we're going. I don't think anything's ever going to work fully until we get to that point. But thank you for having me.
I think there is so much hope in the experience that you've had and that Tracy's had that will unwind this really taut puzzle at some point and have better strategies.
I wanted to let you all know about my daughter is 6 years old. We're in the fenfluramine trial, and that has been very effective, but it wasn't effective in the beginning. So we started the trial, and she did awful. She was in a vegetative state. I pretty much called them and said, look, I don't have the resources for a child in a vegetative state. I mean, I'm going to try my best to stay until the end of the trial, only because all these parents tell me that they're at the end and they have no choices. And that's why I stayed till the end of the trial. And when we hit the max dose, I don't know what happened. Her seizures like reduced from maybe 20 a day to up to 4 a day. And she even had seizure-free days once in a while, which we hadn't seen in 5 years. But during the trial, we have some generic drugs, and one of them is lamotrigine, and that company that made lamotrigine stopped making it. And so they switched to a different generic. And she had more seizures during that time. And that's a big concern for us. You have the brand name, and then the generics could be up to 10% above or below, and then she's on 5 seizure medicines, and she's on multiple generics. And then one day this one changes or they give us a different one. And for our population, I think it's very important that it stay consistent. And I understand, a generic, people will say, oh, generic is the same as brand name. It's not. And I would like for the FDA to hear that for us, when it's a generic, it would be helpful to know the components of what's in the generic. And to have some type of regulation. If a generic is not effective, I can't really tell, because, she has multiple seizures a day. The only way, I have no idea. Is it because we switched the generic, or because she didn't get enough sleep, or because she ate rice today? I don't know.
Thank you.
Yeah.
I like that comment.
It is
I like that comment a lot.
Back here.
Oh, let's go.
I just want to speak to some of the other comments that some other people made.
You're Adam's mom.
What's that?
You're Adam's mom.
Yes, I'm Adam's mom. So we learned so much from each other. When I've gotten together with so many of these families over the years, one of the nuggets that I learned was melatonin extended release. So, it may not work for everybody, but for us, that was something that helped us sleep so much more than just regular melatonin. So he was falling asleep on melatonin because the Pferd keeps him awake. But he was falling asleep and then waking up a few hours later. And I found that with extended release, he sleeps much better. And another thing, thinking about what Jen just said, we've had really good success with clobazam. Banzo helped quite a bit. And now Epidiolex is helping somewhat, I think. But it just keeps changing. What worked for a while, and then he keeps changing. And what becomes really hard for a lot of us is, okay, so now he's on 5 meds. And if we ever want to reduce something or increase something,
where do you
it's
start?
just this big cocktail that you don't know, what do you reduce next? What do you increase? What are the effects going to be? And it just becomes really hard at this point. We don't know what's working really. And then another comment I want to make is Adam's, we just found out the cause of his LGS just a couple of years ago, and I haven't heard anybody talk about this yet. So DYRK1A is the genetic abnormality that he has. So just add that to the list of, hopefully that'll be helpful for him and others someday.
Thank you. I mean, I hear all of these statements you're adding to this rich dialogue about there's the treatment approach and then there's the management of the treatment approach and all of the consequences of side effects and keeping the dosing right and the additives that come into the inactive substances that might be in one generic versus another. That's a lot for you guys to take on. Kudos.
Thank you for having this discussion. I hear a lot of parents talking about other things other than at the epilepsy seizures that their children are having. The associated not sleeping, respiratory illnesses, gastric illnesses, all that works to make one big huge picture. You don't know which to handle. My son's 18 now, and when he was, I think, 5, I had a neighbor who uses essential oils, and she saw that we had been in the hospital 2 times for respiratory illnesses, and came over with a respiratory blend and a immunity blend, and said, I know this isn't something that you normally do, but you know, I'm a nurse, so I understand the medicines. And she said, just try it, it can't hurt. Put these on his feet. You know, you don't have to directly use them on wherever it is. So we used the immunity blend on his feet twice a day. We used the respiratory blend when he would get a little stuffy. And we did not go to the hospital again that whole entire winter until I stopped using it in the spring, and we all got colds. Now, we all used it. So there's a lot of different, I think the point I'm making is, you know, you have to kind of look at the whole picture of your child, you know. Like Adam's mom just said, the melatonin to help sleep. There's all kinds of like lavender products and different frankincense and, you know, eucalyptus and diffusers, and you know, that's actually, the diffusers have become a lot more commonplace. You know, I have to stress, use a natural essential oil. Don't go for the synthetic ones that you find at Whole Foods or, you know, at Trader Joe's. Go for the ones online that are tested. It has increased our well-being, my son's well-being, and because at one point we weren't even worried about his epilepsy. We were worried about everything else going on with him, and just hoping that one day he wouldn't die of pneumonia. Never mind his epilepsy.
Right.
You know,
it's a great point to remember. This is a holistic picture, and it's hard to tease one thing out of the mix and just only focus on it. You've really got to take so many factors into consideration. We talked a lot about the meds. We also heard from our panel and from several other people about medical devices, whether it's the vagal nerve stimulator, the importance of the durable medical devices that help your kids through monitors and you know, just the assistive devices, the wheelchairs, the breathing apparatus, experience helmets. Yes, boy, we saw a lot of those in the pictures, didn't we? Medical devices, are those approaches beneficial? How do you weigh those decisions about that?
Hi, my name is Gabi Conacher. I am the mother of Elliot, who is just 6.5 years old, and he has an SCN8A mutation that is the cause of severe issues for him. Epilepsy and seizures are one of them. It's when he was born and the first couple of years of his life, seizure were the major issues. We've gotten some control, but what has become more and more difficult for us is respiratory control. I haven't heard a lot of people talking about, I've heard a lot about behavior, but for Elliot, quite frankly, he doesn't have a lot of outward behaviors. He's severely hypotonic, so he's confined to a bed most of the time. We do get him up in a stander or a chair if he's strong enough, but frankly, he aspirates a lot when he's in a chair and a stander, so He's not able to be upright, which means he can't get stronger, which means he can't learn, which means he can't be active and engaged in the world around him. And it means that we can't leave the house. It means that we can't have people come to the house because we're scared of germs. And frankly, it's one of the major issues for us, not just the seizures, but the hypotonia, the secretions. He's had salivary gland excision. He's taken all of the drugs that dry you out, all those kinds of things, and it still hasn't helped. And so it means that, he doesn't get to engage in Halloween or any of these other things. I see all these people dressing up their kids in these amazing things in their wheelchairs, and we just can't do that. He can't be sitting up. Also CVI, so like a cortical vision impairment that keeps him from being able to engage with the world around him in a lot of meaningful ways. And then the equipment, just to touch back on that, we essentially have an ICU at home. And having all of this equipment, we have a pulse oximeter, we have nebulizer, we have cough assist, we have a vest, we have suction, we have almost every machine you can think of. And my husband and I have become nurses, and we never leave his side. One of us is always home, within reach. We have nursing care, but frankly, the people that they put on nursing for these incredibly fragile children are not very well trained and not very motivated to engage and do a lot of the interventions. So it just has meant that we don't have any friends anymore. We never leave the house, and we're constantly scared about. You sitting here, I'm checking the video monitor at home, making sure the nurse is doing what she's supposed to do, looking at the pulse ox. I say, you always have to keep it so I can see it. Mm-hmm. So it's just a different side of things. I think that the behaviors are really intense and scary, but it's also really scary when your kid just lies there all day and you have to do every single thing for them. He can't eat, he can't walk, he can't talk, he can't grasp. He gets his arms in weird positions, and the pain threshold, he won't cry, so he's stuck there. You have to be monitoring 24 hours a day. So I think it's just a lot of really intense things to think about. And I think having a better sense of meds and the side effects and the, he's incredibly sedated all the time because he's on 3, 4, 5 AEDs at any given time. And so having a better understanding, and Leah talking about the precision, it's like, that's what we're pushing for.
Absolutely.
And our hope is lying in that.
Thank you for giving us a little window into all of the care supports that you need to help your son. Tracy from the web?
Yeah, I know we did have one family that had tried more than 48 different drugs on the web. The comments have been amazing, and we'll make it into the report. I did just want to touch on devices. I don't want that to be missed. About 40% of the population that we surveyed here currently have a vagus nerve stimulator. And for us, we had no idea if it was working or not. We got it implanted, and then we didn't quite realize that just meant more and more surgeries. So every time the battery would die, she'd get another surgery. And not knowing if it worked or not was really a problem. At one point, at her 5th surgery, they put the VNS too close to an area. Our kids tend to be very thin, many of them, and lots of scar tissue. And she kept complaining it was hurting, and 30 days later, there was a hole in her flesh from where the suture had worn through as it was rubbing in place, so they had to do another surgery, and I guess now they can put them on the back. But we finally weaned it, and we did see a tiny uptick in seizures, and there was sort of this withdrawal, and then they went back down. But we just couldn't do a 6th surgery, and you don't quite think that when you try it. You just think, oh, hope, and then you're like, I have no idea if this thing's working or not. Yeah. And so stimulate devices are a great option, but they also, I didn't fully think through the implications of putting that in and needing a battery and what that meant, and really. So
Karen had mentioned a number of surgeries to move and replace your son's device, right? It's these benefit-risk decisions that all of you make, that Dr. Campbell spoke to at the beginning of the session, that the FDA has to weigh the evidence when something new comes before them, but you all are making these kind of benefit-risk decisions on the fly, minute to minute, moment to moment, and none of them easy, none of them, easy choices to make. Dale, in his testimony, had mentioned the change in the rescue medication. I think this is tipped along. From needing to use a rectal gel to something that was in nasal spray form. And just wanted to invite you to tell me, let's think about, how does the mode of administration, several of you have mentioned extended relief formulations of medications, how do those changes, maybe not in the substance, but the way it's delivered, help you to better care for your child? Anybody have a quick comment on that? Nicole? Oh, Kim, go first.
Sorry, I just wanted to go back for a second because after I sat down, I wrote down all the medications that Michael has been on. He's 31, so
Okay.
this is several years of medication. And it's 24 different seizure medications or therapies. And currently, he takes 4 anti-epileptic medications, but he takes 6 other medications as well to counteract some of the side effects of the anti-epileptic meds.
Yeah, thank you.
Thank you.
Nicole had a point about the kind of mode of administration as we think about giving some direction to what an ideal therapy or set of therapies might look like.
For us, we have several rescue medications. We have Diastat, clonazepam, Versed, which is the nasal spray. Here's a couple quick that I could possibly think of. We also use cannabis as a form of rescue. Most of the time I will go for that. 95% of the time it is effective and it works better than the pharmaceutical rescues, only because there's no side effects. Jeremiah's not a drunk little sailor. He's not angry. He's not ripping walls, tearing heads off. He may be sleepy, but other than that, we are fine. I don't have to ship my kids off anywhere. Everybody's safe. Now, here's the other thing with the nasal spray that I think maybe Dale mentioned, and I don't know if it's the same one. Jeremiah has continuous sinus issues and cavity issues, so I can't get in all the time to get it, so it'll just come right out. Diastat, well, he's almost 7. Not really appropriate to be trying to pull somebody's pants down and, do that.
Not only that, but if you're in a vehicle driving.
Oh yeah, that too, so it's not convenient. I was the person that brought up the cannabis use, so I wanted to make sure since I have you in here. In California, we are a recreational state. I just spent a whole day yesterday before coming here in an IEP because it's not allowed on school grounds. But yet it's more effective than most of his medication plans. And it's not just CBD I'm talking THC, THCA, CBG. There's other cannabinoids that are being found and researched, but without that ban, there's not much we can do. But as far as the rescue medication, again, we're dealing with behaviors because of the rescue medication, and it's effective, but look at the behaviors, and from what you've heard from this room, the behaviors are almost worse than the seizures. In my opinion, they are, because I could deal with the seizure. Obviously I don't like it, but I could deal with the seizure and we move on. The behaviors are just off the chain with the rescue medication. In fact, I had to have a talk with his hepatologist because when he takes clonazepam, he is psychotic. I don't know if it interacts. There's an interesting, right now we're trying to see what's going on with that, but the Lamictal and the clonazepam they think are interacting, making it untherapeutic. But there's no real study on that either. So he's sort of the oddball. Jeremiah is an oddball. I love you because I know you're watching. But he's an oddball. Every rare side effect that you could possibly think of that are uncommon, he has had, and he leaves his doctors stunned because he's like, I don't know. So just throwing that out there.
Great, thank you.
Can I hop in for a second, Kim? I know we're wrapping up
Yeah.
here, but I just want to mention kind of what I'm hearing and what we've saw in the survey and what all of us talk about when we get together. But
if you think about what you've heard today, there's crisis, there's emergencies, right? There's keeping our kids out of the hospital, keeping them from being injured, keeping them from having to take rescue meds. Those are all things that we don't count right now, that we could count instead of just a 50% reduction in seizures for a medicine. And so you've got this sort of crisis, and then you have at the next sort of level in this sort of hierarchy of issues that we're dealing is safety and preventing them from going into crisis. I mean, are they safe? Are they going to end up in the hospital again? Or are they right at the cusp? Are they not taking their meds? Are they in the throes of going into another rage behavior? So it's sort of that pre-crisis, you know, and can you keep patients out of crisis, and then can you keep them out of pre-crisis? And then you can start talking to us about things like, how's it going in life? How's school? You know, can they do anything for themselves? Because if we're in crisis mode, which we are constantly in, there's a really great paper that was published by Ann Berg about how we just keep going into crisis over and over, or we're at the cusp of crisis every time, and that crisis can be a behavior. That crisis can be a hospitalization. If the FDA, my daughter had so much rescue med, and all of the rescue meds were used for non-convulsive status, which they are not approved for. And I'm confident that they were making her need more and more and more and more of this rescue med, because she would go into these non-convulsive seizures, which doctors tell me aren't countable in clinical trials, but I promise you when they go on for hours, we can certainly count that as something. So we're using this med, we don't know how we're using it on a seizure type that's not being studied because it's not countable. If you would have just kept us out of the hospital before rescue meds existed, which I remember, I would have been lined up out the door for that FDA drug, regardless of what it did to seizures. Just kept us out of the hospital, kept us from using rescue meds, kept us from busting our face open, and then, you know, reduce the behaviors. And so I think there's a lot of opportunities beyond.
And I think you help us transition to what I want to do with the last couple of minutes we have is, all of you have spoken of the need for new medical options. And the only way we get to those is through clinical trials and more research. And Tracy just pointed out some outcomes that could be potentially meaningful in terms of the priorities that you all have described. So just by show of hands, how many of your kids have participated in clinical trials to date? Quite a few. And just some quick observations. We only have time for a couple. But of what was positive about that experience, you shared yours, that it was tough at first, but now you've gotten to a point where it helped. It could be in terms of the therapeutic benefit or just what you learned or the opportunity that you had. Go back.
Oh, sorry.
Two things, just to comment on what Tracy was talking about. One thing that I haven't heard anybody talk about is with the rescue medications, a lot of them are benzodiazepines, and Adam just built a tolerance to them when he was little. We used Diastat so much, he just laughed at Diastat.
Yeah.
I mean, it didn't stop the seizures, but it gave him all the side effects, groggy. So that's one thing to consider with research. And then I was going to speak to your other, the clinical trial. So the clobazam was so effective for Adam. We started it in July, I think, 2010, and from July 1st to July 23rd, he had drop seizures every single day. And then from the moment he put that tablet in his mouth, and it was a double-blind, randomized clinical trial, no drop seizures.
Wow.
So, I mean, it was
dramatic.
Shocking. You know,
dramatic.
That was really a...
game changer for you guys, as somebody else used that term.
Mm-hmm.
Thank you, Sarah.
We also did the clinical trial for the trigeminal nerve stimulator, and like I said in my testimony, saw an 82% reduction rate, and that was overall, I mean, no seizures. And so Kanan had only ever had 17 seizure-free days between the time he was 3.5 to 7 when we started that trial, and so to have an 80% reduction, I mean, I got him back, you know, for a good 6 months. And then it was canceled. And so that was a really, really tough thing to lose all of that again. And then to the rescue med point too, I think it's really important to say how so much is put on a parent as far as the insane choice you have to make. I feel like over the course of 8 years, we have planned Cannon's funeral. And I don't know that anybody in a doctor's office could ever understand that, or at the FDA. And we have come to the realization that there's nothing inpatient that's going to happen for Cannon. If he has non-convulsive status epilepticus, I want him home with me. And to really have to know and own that there is a likelihood of death in a child is something no parent ever should have to wrap their head around, ever.
Every waking moment that weighs on you.
Right.
Kathy, Michelle has a comment. Or sorry.
Okay, just for a moment, I just wanted to go back to the medical devices, and there's still work to be done, and I feel like if we can improve in that area, we can prevent so much. The Embrace Watch is great. I know for a lot of people, it didn't work for my kid. Someone's with her every second, so if she's having a tonic-clonic, we can visually see it, so that's not necessary, that sensor. And also the problem with that too is I found that my phone would have to be beside her bed, and it wouldn't send an alarm to my phone across the hall. And she doesn't sleep with me. I might be the crazy mom that doesn't sleep with her kid. But you know, that kind of technology really needs to improve, and I think it will help our population. The EMFIT mattress monitor has been an absolute godsend for tonic-clonics. Now, quite often I'm at her bedside because I've heard through the baby monitor the sounds of a tonic-clonic before the alarm goes off, but nonetheless, that's great. But what about the tonics? What about the silent seizures that sensor doesn't pick up? That rapid and repetitive movement is what's missing. So then there's the Wise, or whatever brand you want, there's the cameras that record movement and motion. Those aren't alarming you, though. You can play back the next morning. So you see there's so many deficiencies, but I think if we can improve that technology, we won't be missing as many seizures and perhaps even prevent SUDEP. And one more thing about, for example, the VNS. My daughter just got one in June, so I'm learning about it. And I know that it does look at her heart rate, and if her heart rate increases, it'll send off a stimulation. When she was in status, though, her heart was barely beating. So what about when the heart's decreasing? And either way, it's not sending off an alarm to me. It's just later when they interrogate that they see that event happened. So I just want to mention that with technology, there's so much more that needs to happen, but I'm grateful for where we are. Let's just improve that and we can save lives.
I think that's a great note to end on. We're almost at the end of our, okay. I'll give you one chance, and since you haven't spoken yet, Michelle.
My name is Michelle Welburn. I know a lot of you guys just from years and years of being a part of this community. I have a daughter with Dravet syndrome. Professionally, I actually am a regulatory consultant, and I help companies develop drugs for rare diseases, and I've spent a lot of time with the Division of Neurology over the last few years. And I guess the thing that I want to say, and I just want to kind of validate what everyone's saying about the treatment of Lennox-Gastaut syndrome or Dravet syndrome or whatever developmental or epileptic encephalopathy we're talking about, is the drugs that are approved are for the treatment of seizures associated with these syndromes. And I would really encourage the FDA to think about the syndrome when approving drugs and work towards trying to help companies get validated measures of other things like quality of life that we're talking about that actually really impact the child or the adult and their families sometimes more than the seizures. The problem is we don't have validated tools to actually prove that these outcomes are affected. But I think it's really important, and I think hopefully we will have drugs that will one day be for the treatment of Lennox-Gastaut syndrome instead of seizures associated with Lennox-Gastaut syndrome or Dravet syndrome.
Thank you, Michelle.
Amen.
Almost like having closing regulatory comments to have your lived experience and your professional experience wound in one. Well, I'm, stunned at how quickly the time has flown and how many topics we didn't have a chance to cover. But I think this was a good start at a conversation that obviously will need to continue because, as we saw this morning, there are new technologies, the genetic understanding of some of the origins of LGS and DEEs are being uncovered, and that will yield new opportunities for research and treatments that we can't even forecast right now.
Can I just make a comment that I think everybody's aware of it, but I think it's important to say it and acknowledge it, is that I know that I'm not the only LGS mom here or dad here, but I know that I'm constantly checking my phone because I know something's going to happen. So there is nothing that I do in my life where I'm not checking that phone, seeing if something's going on with my son, Andrew. I don't even go, I get my 45 minutes of boot camp, maybe 4 days a week, but I literally am going between exercises, checking my phone to make sure he's not having a seizure. So I never get that break. So I just think that everybody needs to be, and the FDA needs to be aware of that. The parents, the siblings, whoever's taking care of that kid, they don't get a break. They don't. They're up at night. I'm at work. I work in a clinic, and I'm constantly checking my phone before I take that triage call, before I room that patient, before I hook up that EKG to the guy that's really not critical at the moment. I'm checking my phone before I walk away to make sure I'm not missing something when I disappear for 15 minutes. So
Thanks.
I just think that's important.
Thanks for that. And that is one of the topics that we didn't have time to go into as much depth as we could have, is the impact on family systems, on relationships, on all of your health as caregivers, and what the impact then is on your child as your health changes. I'm sorry, we're just out of time. We heard today so many important key themes that I think the Foundation and the FDA and the life science companies listening in will certainly have as takeaways from this discussion, beginning with just the challenge of even classifying these conditions, of categorizing them, of diagnosing them, of treating them in a rational fashion based on evidence that really supports the kind of everyday, minute-to-minute decisions all of you have to make. We heard about the importance of seizures and the very many different seizure types and how you might prioritize and rank those if you had the magic wand to be able to lift 1 or 2 or 3 different types from your child's experience. The impact of behaviors and the tough decisions about which is worse, the seizures or the behaviors, and how those impact your kids' lives and your lives. The developmental aspects of these conditions and the yearning that you have for them to have more normal development, cognition, intellectual development, interactions with adults and kids their age, all just, heartbreaking. I think one of the key messages I heard is just the painful trade-offs you make every moment of every day about how you're going to manage the very immediate short-term needs of your kids against the long-term consequences or potential for adverse events or consequences, and the enormous amount of uncertainty you're dealing with. So much of what you do is not in the literature. It's not in any expert's head. You guys truly are the experts because you're creating the evidence base as you're living it. And with that, we're right at the end of our time. I want to thank again the panelists for their preparation. I want to thank again the sponsors, the FDA, for creating this meeting series and allowing the Foundation to convene today's setting. The FDA and NIH folks who are here, but mainly all of you experts. Everybody with a ribbon on their badge deserves just so much credit for coming here, for being part of this, for offering up such deeply personal, painful experiences to benefit not only your own families, but families across the world and generations to come for the hope of a better future and a better life. with these conditions, with the hope that someday they won't exist at all because we'll have solved it. And with that, maybe Christina gets the last word.
Thank you so much, Kim. Thank you for your leadership today and for your organization. And for keeping us on time. I just want to say thank you to everybody one more time. And just one note. Today, as I mentioned earlier, is LGS Awareness Day, and we will be going to the Baltimore Zoo for our annual event. So there will be a transportation bus at 4:30 heading to the zoo. For those of you that don't want to wait around, during the afternoon, you're free to have your own time, hang out with me, or, or go to the Baltimore Aquarium, and then we'll meet up at 7 o'clock is the time for the event. So happy LGS Awareness Day, and thank you again to Kim and all of you for being here.
Kim.
One last announcement is in between the zoo and now, there will be a meeting in this room this afternoon, and we're going to have a joint lunch with members of the CDKL5 deficiency disorder community who will use this room from 1:30 until 5 to host a very similar conversation about challenges in the CDKL5 deficiency disorder experience. So I think we can use this room during the lunch period, and then if you're not staying on for the afternoon session, just clear out your belongings and make way for your fellow experts from the CDD community. But again, thank you so much for your participation and your attention this morning, and we'll see you at the lunch table.